I think we're live. Hello, hello, my friends. Jill Osborne from the Interstitial Cystitis Network. It is Sunday, December 15th, and it's time for another support group meeting. I got a problem with the microphone here. Hold on one sec. Let me just see if I can get this up higher. A little sniffy nose today, mostly because it was just really cold last night. All right. We'll see if that works. Is that going to work? Maybe. We'll see. Hello, my friends. It's Jill Osborne from the Interstitial Cystitis Network. And again, it is Sunday, December 15th. I swear, time is flying by so quickly. Just feels like yesterday was Halloween. Hello, Gay. Nice to see you, hon. So my purpose in doing these meetings is to make you so strong, knowledgeable, informed that no one can demean you or diminish you or insult you or anything at all like that. Our goal here is to give you knowledge, to give you strength, to give you support, to give you encouragement, to give you love, and to let you see another person who has the condition that you had and who is symptom-free. It's hard when you're newly diagnosed. It's very, very hard when you're newly diagnosed. So I'm live streaming now. If I'm looking this way, I'm looking at Facebook. If I'm looking over here, I'm looking at YouTube. My internet was down. They just got it back up. That's one of the reasons why I've been a little slow. We had a giant storm here in California. It's a crazy storm 2 nights ago, and all my phone lines were down and our DSL was down, and it was crazy, but we seem to be back now. Yes. So normally when I do these meetings, I always do a little 30-minute intro. I don't really have anything prepared today, but I want to make a couple of offerings here. Number one, does anybody want to exchange Christmas cards? I love exchanging Christmas cards. And I would love to send you a Christmas card. If you would like to get a Christmas card to kind of lift your spirits, please pop me an email. My email is icnetwork@mac.com, icnetwork@mac, M as in Mary, A as in Apple, C as in Charlie.com. Send me your snail mail address. I will be happy to send you a Christmas card, and I'd love to get a Christmas card back. You know, it's funny, as I'm getting older, I'm like, trying to, especially around the holidays, because when you're struggling with pain, when you're struggling with a disease, when you're struggling with cancer, when you're just struggling, holidays are hard. And you know, I was thinking about that this morning as I was supposed to be baking this weekend, and I wasn't. I was out doing things after the storm went through. And you know, there's always this like pressure to make the holidays perfect. And I think that we kind of ruin it for ourselves because sometimes our expectations are so high that it's almost impossible to make it work. God forbid you have a flare. God forbid you're supposed to maybe make cookies one day for everybody, or get ready for your holiday meal, or to bring everybody to your home and you know you have to clean, or you have to decorate or put up a Christmas tree or wrap presents, things like that. You know, listen, I'm sorry, that's really hard if you're having a flare. That's hard. I hear you. I see you. I've been there. Oh, no sound? Oh, here, hold on a sec. Wait. What happened with our audio? Oh, yikes. Testing 1, 2, 3. Facebook, can you hear me now? Facebook, can you hear me? Testing 1, 2, 3. Testing 1, 2, 3. Yay! Oh, you know what? This is like a really good lesson for me today, and it's kind of a good lesson for what I was just really kind of talking about. Okay, Anne, you should be able to hear me now. Can you hear me now? I want to hear consensus on Facebook. Yes, Rebecca says she can hear me on Facebook. Kayleen says she can hear me on Facebook. Okay, then I think we've got Facebook fixed. Let us hope we do. I got this microphone being bonkers here. Hold on. Okay, so let us start that discussion over again, shall we? Okay. And for those of you on YouTube, please bear with me here. Listen, it's the holidays. We got it. Sometimes we take it minute by minute. Sometimes we take it hour by hour. Sometimes we take it day by day. What I was talking about before I realized you did not have your sound because I had it set to the wrong sound setting. My bad. Is I was thinking about this as I was running around. I even was out this morning. I had to do some shopping this morning to grab wrapping paper and things like that. And as I was driving home, it was just like dawning on me, reminding me that sometimes we set our expectations way, way, way too high. Listen, you don't have to be perfect this holiday season. You don't have to make the perfect cookies. You don't have to decorate the perfect tree. You don't have to set your expectations so high that you're almost dooming yourself to failure. Listen, life with IC is hard. Life with pelvic pain is hard. And the holidays are really extra, extra hard because there are expectations that family members put on you, but they don't necessarily know how you feel. Like I'm having a good weekend. I've had a lot of bad days recently, but I'm having a good weekend right now. But I don't know what it's going to be like on Christmas Eve. I don't know what I'm going to be like on Christmas Day. It's one day at a time, my friends. And I mean, honestly, it's not your fault. I don't want you to blame yourself. You're doing absolutely nothing wrong. If anything, you're a warrior. You are surviving. You are thriving. You are trying to help the people around you, despite the fact that you are struggling right now. And you deserve to be admired, and you deserve to be appreciated, and you deserve to be loved. But I don't want you to try to be perfect. I was thinking about this just like literally half an hour ago. As time goes on and you lose more people in your life, everything changes. When you're young, it's all about the gifts. What are you going to get? I still remember when I was in 5th grade, I wanted this little racing car set and I never got it. I still remember that. And I'm 64 now. But that's the only thing I remember. Other than my Aunt Shirley and I we always used to share a gag gift with each other, which always had us laughing here hysterically. It was usually a silkworm. It was disgusting. But anyway, we got big laughs over it. People don't remember the gifts for the most part when you're older. They remember the memories. They remember the laughter. They remember making cookies with your dad. They remember making Christmas bread, which is one of my biggest memories. They remember playing games. The best gift you can give is not money spent. It's your time. And listen, if money is tight for you right now, make cookies. Make cookies. Make a batch of cookies and give them. If you've got a family member that's distant and you can't get to them, call them up. Brighten their day. It's not about the things, it's about the people. It's about the people that you love. It's about the people that you care for. So don't exhaust yourself trying to make it perfect. Nobody will remember a perfect Christmas, but they will remember the jokes. Like my grandmother making weevil soup. My grandmother Betty, whose eyes were quite bad, went to my Aunt Mary's house with all of her kids. She had 4 kids and her husband, and she was making them some sort of like meatball soup. Well, she put in rice or pasta, something like that. Just had it simmering on the stove for a couple of hours and like smelled great. Everybody sat down at the table. They stirred up the soup. One of my cousins lifted it up, looked at it, and went, is this a bug? It turned out that the rice she used was weevils, like massive weevils. Now that is a great Christmas memory because everybody laughed over it for years and years and years to come. And that's what I wish for you. I want you to have sweet, happy, joyful memories. And if you're hanging out with family members or friends, go slow. Don't get, like I always say, I try, because I learned early on when my IC was particularly bad, that it was very, very important for me not to get anxious over the holidays and will I get there or won't I get there, because I just made myself sick and miserable. I always told everybody, listen, I want to be there. I have every intention to be there, but ultimately it's going to depend upon how I am in the morning. If I'm good, I will be there. If I'm not good, I may stay home, but that doesn't mean I don't love you. And that doesn't mean that I'm not going to be thinking about you. And that doesn't mean that I'm not going to miss you. It's okay to put yourself first. I think a great holiday, to be quite honest, is playing games. Few presents in the morning, playing games throughout the day, having whatever appetizers you like that are your IC friendly, whether it be potato chips or carrots or whatever. Just making those really, really sweet memories. So if you're struggling, I hear you. I see you. You're not alone. You're worthy of a wonderful holiday. You're worthy of joy. You're worthy of kindness. And you're worthy of peace. And that means the good peace, the sweet peace, the happy peace. And again, if you want a little bit of extra joy and you'd like to get a Christmas card from me, please send me your address. My email is icnetwork@mac.com, icnetwork@M as in Mary, A as in Apple, C as in Charlie.com. Would love, 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 love to send you a Christmas card because I got some really cute, funny ones. So anybody out there, you want one? That's fine. Hello, Jeannie on YouTube. Hello, Ann on YouTube. Hello, Shimper on YouTube. All right, Facebook, we've got a small crowd. I didn't think we'd have a lot of people today because honestly, people are watching football, but even more importantly, you're trying to get your act together. Hold on one sec. Okay. Pamela said, I had an MRI on my back. My doctor called, wants to see me tomorrow. First ever MRI. I hope it tells me something good or bad after 24 years in pain. I had another MRI in November. It was on Panaceas. I don't know what that means. Pancreas. The office called, said no big deal. Come back in a year. After 5 years of testing and mass on my pancreas and cysts on my kidneys, no worry, they say. You know, I have a hate relationship with healthcare right now. I mean, honestly, y'all need to stop stressing us out. You know, we had the murder of the head of United Healthcare, and that is so incredibly tragic for his family. But from what I've been told, the man who took his life had back surgery and had terrible pain after that surgery, and apparently United Healthcare wouldn't cover him. And I think that we all can understand the toll on our mental health that untreated pain takes. And I truly hope that, you know, as all these stories are coming out of people who have been denied life-saving health care and family members sharing how a medication was denied that led to suffering as somebody, you know, was struggling with cancer or end of life or something like that, I truly hope that this is a wake-up call to those executives at United Healthcare and all of the health insurance companies. Because let me tell you, I'm a member of Kaiser Permanente, and they've never denied me care for anything. But there are issues. There are definite issues with the healthcare system that they provide too. Particularly delays in care, getting care in a timely manner is very, very difficult. And so I am truly hoping that the health insurance industry that is making billions of dollars every year while cutting back services and care for all of us has a moment of reckoning. Because we've got patients here who are suffering. And if we're paying you our hard-earned money, then we deserve care back, just like we paid into Social Security. Social Security is an insurance program that we paid for. And if that gets cut, then I think we all need our money back that we paid into it. So I don't know. Like, I talked to my doctor on Friday because my thyroid is doing all sorts of weird things. Again, at this point in time, I could almost care less. And she's like, "Are you on biotin? Are you biotin?" And I'm like, "Yeah, I was taking a multivitamin biotin." She goes, "That's it." And she wants me to go back to the lab for the third time. I just don't even know what to say. Except, Pamela, I truly wish you the best. And I truly hope that your MRI results come back good. And I hope that you can have a peaceful and joyful and sweet Christmas. And for those of you who are facing major illness like cancer, if you can just try to disconnect for a couple of weeks and just try to let the spirit of the season infuse you with some warmth and comfort and love. It's hard to do. I know it's hard to do. I mean, last year I was grieving my parents. This year I'm just traumatized from having cancer surgery. So Pamela said, "Mom died at 45 of cancer, never left the hospital. And she turned 45 in the hospital." Oh, honey, I'm so sorry. And that's hard because you lost her right before Christmas. And so those memories are infused with Christmas. But here's the thing I know. Your mom and my mom would want you to have a wonderful Christmas. Your mom and my mom especially, is like, you decorate that house. Girl, you decorate that house. If not for you, do it for me. This is our family home. You will fill it with light and love during the holiday season. Angie said, "You look really good today. Thank you. Better than I've seen in a while. I'm so glad. Hope you're doing well. Oh, I can't stay, but wanted to wish you a Merry Christmas." Thank you, honey. I am doing a little bit better. Angie says, can you talk about embedded UTI and the relationship to IC? There is no relationship between IC and embedded UTI. The whole embedded UTI thing is just, guys, it's been around for 30 years. We've been fighting this misinformation for 30 years. Our next generation DNA urine testing has never found embedded bacteria other than a lactobacillus. You know, this whole group of people who began back in the 1990s suggesting that every IC patient has an embedded infection, despite the fact that pretty much every round of testing, including next generation DNA urine testing, has never found a pathogenic bacteria like E. coli consistently in IC patients. And now that we're phenotyping, we understand that a lot more because 85% of IC patients are neuromuscular. I mean, guys, you got to understand the bladder only knows one language: frequency, urgency, pressure, pain. Everything feels like infection. A bullet wound would feel like infection. A stab wound would feel like infection. Cancer feels like infection. Everything feels like infection because that's the only way that the bladder can tell you that there's a problem. But when testing comes back negative, despite those people saying they've missed it, understand that when testing comes back negative and your bladder looks healthy on cystoscopy, then we have to look beyond the bladder. We have to start looking at muscles and nerves, because we now believe that 85% of IC patients have a neuromuscular origin rather than a bladder origin. And we had just had another study come out last week which proved that pelvic floor muscles are actually more consistently cause symptoms of frequency, urgency, pressure, pain than the bladder wall itself. And so for a lot of us, myself included, when they look at your bladder and they find a completely normal bladder while you're crying in pain and up every 30 minutes, you're going, how is that even possible? Surely I have the most disease-damaged bladder in the world. And yet they look in your bladder and they find nothing wrong. That's when we look outside the bladder and we look at muscles and nerves. And when we looked at my muscles and nerves, that's where we found the problem after decades of doing bladder treatments. Diva, hello, Diva. Nice to see you. Diva says, I have several autoimmune conditions: Crohn, lupus, rheumatoid, psoriatic arthritis, fibromyalgia, blood clot disorder, gastroparesis, and IC. And you're having bladder surgery every 3 months? Girl. So I do believe that there is the autoimmune component is a small subset of patients. It's a real subset of patients. And some would say Hunner's lesions fit into it. I don't believe Hunner's lesions fit into it. But this is where a medication like cyclosporin might be particularly useful, but more importantly, just lactoferrin, giving that we have the new research with lactoferrin, which shows that lactoferrin is remarkably good at reducing inflammation throughout the body, reducing inflammation in the bladder, making red inflamed bladders pink and normal and healthy again. And in some cases, Hunner's lesions disappeared completely. And that was a study that came out last August. So it would be very interesting to put lactoferrin on board. And for those of you on YouTube, you are on a 2-second posting delay. So if you're trying to write and it's stopping you, we have to do that because spammers sometimes come in. If you're not able to get a question out in the chat, you can email me, icnetwork@mac.com. You can email me your question and I will do that too. Here's my bladder-friendly drink of the day: coconut juice with mango. Yeah, baby. No saturated fat. I came to realize that one of the reasons I haven't been doing particularly well in the last month, I was having just a lot of diarrhea and gut upset, is because after my gallbladder removal, I had to cut back on saturated fat, but I was eating a lot of avocado. And I now realize that, and I was using avocado oil, that I can only do 1/4 of an avocado safely. If I do half of an avocado, I will be in the bathroom all day the next day and I will have nausea. Now that I've cut way back on the saturated fat again, I finally feel better again. So, hello, gallbladder removal. So Angie, so getting back to this whole concept of embedded infection, when we started using next generation DNA urine testing, rather than trying to grow bacteria, instead what they do is they take a urine sample and they blend it up really fast, shred all the bacteria and isolate the DNA. And then they match those strands of DNA to a big database to identify it. Next generation DNA urine testing finds everything. It finds bacteria, good bacteria, bad bacteria. It finds fungus. It can find virus if a viral test is done. COVID testing is actually next generation DNA testing. So if you have a next generation DNA urine test and that comes back clean, then you need to walk away from the whole embedded UTI thing. I mean, that's a whole industry. More importantly, I mean, the people online who have been talking about this again for a very, very long time, they all say y'all need to be on long-term antibiotics. But now we're starting to identify and see the toll that long-term antibiotics, even short-term antibiotics, take on the bladder. Because when you take antibiotics, you kill the good bacteria, most of the good lactobacillus, but there's one lactobacillus that's not a good lactobacillus that grows and dominates the biome, and it behaves like a bad bacteria. It's called Lactobacillus inners. So now we have a very strong emphasis at the American Urology Association in their courses on IC. They are literally begging doctors to stop giving antibiotics because of the toll that they take on the good bacteria. And I can give you the exact quote. I did yet another big presentation to another pelvic pain group this week. I have a 45-minute presentation that I'm doing on phenotyping. And let me read you the quote. This was from Dr. Ann Ackerman, who was one of 3 teachers on IC at this year's American Urology Association conference. She said, quote, "There are systemic effects for antibiotics, which might include the enrichment of species like Lactobacillus inners and the overexpansion of fungal species like Candida. And these may have long-term, very long-term, bigger consequences that we must keep in the back of our heads." So when you take an antibiotic, you're killing the good bacteria, which then allow fungus to grow. We already have multiple studies, including from our own National Institutes of Health, that has found Candida infections in IC patients. And the more Candida found, the greater the bladder pain. If there's a group of patients that is massively overexposed to antibiotics, it's us. Because we all go, "Hey, doc, I have an infection. Can I get some antibiotics?" The doc goes, "Sure, I'll give you some antibiotics." They don't work. You go back, you have a urine test, it's negative. The doctor goes, "Oh, just in case, let's put you on long-term antibiotics. We'll do prophylactic antibiotics for 6 months." Doesn't work. You go back to the doctor. Doctor goes, "Oh, let's try some bladder medications like ditropan and Detrol." They don't work. And eventually somebody says, "Hey, guess what? I think you have interstitial cystitis, this incurable bladder disease," which of course we don't even look at as an incurable bladder disease anymore. IC is a bladder pain syndrome for which there are many potential causes, and the great majority of us have a neuromuscular origin for our pain as compared to a disease. The only patients who have a disease are patients with Hunner's lesions, and we now know that Hunner's lesions have been connected to active viral infections in the bladder wall. Epstein-Barr. I was working with a patient last week. Literally, her symptoms started 4 months ago. She's in her 40s. She was diagnosed with Epstein-Barr 4 months ago. And the Epstein-Barr virus has been found in the bladder. She had no prior history of bladder issues. She gets Epstein-Barr, she gets mono, and within a couple of weeks, she develops these severe bladder symptoms. It's actually ideally, once they get the viral infection under check, if they can limit that viral growth in the bladder, maybe Hunner's lesions won't develop for her. We will cross our fingers. Okay, so hold on a sec. So Cassidy, well, here, hold on a sec. Boria says she's got really, really severe COVID. Honey, I'm so sorry. Rest up, girl. Go slow, go easy. Speaking as one COVID survivor, listen, nothing's going to come quick. The most important thing you can do is stay home and rest, go slow, warm soup. And do exactly what your doctor tells you to do, honey. And hopefully you're taking Plaxivit, or what is it called? What's it called? Okay, it's on the tip of my tongue. Cassidy said, I tried cyclosporin. I have Hunner's lesions. Unfortunately, it didn't help at all. Okay, so Cassidy, given the fact that, okay, and hold on, she says, next generation testing, unfortunately, didn't reveal anything super big for me. Besides, I have quite a few antibiotic resistant genes, which are always awesome to know. Yes, yes. So isn't that interesting? So you've had the test. Now you know you've got very strong drug resistancy. So that's good information for the future should you get pneumonia or something else like that. So that's good. So let's go to the concept of Hunner's lesions here. So Hunner's lesions are wounds on the bladder wall. We've got two prevailing theories on what causes it. The first one is a viral infection, and that's very, very solid research. Multiple studies now have connected the virus Epstein-Barr or polyoma BK or polyoma JC to Hunner's lesions. It's in the urine of patients with Hunner's lesions. So I would ask you, Cassidy, do you have any history of mono? Okay. Now, also, given that fact, it would be perfectly reasonable for you to try lactoferrin, because we had a research study come out in August. It was a fantastic research study. It was small, 31 patients, all with a history of IC flares, some with lesions. What made this study profound is they didn't just test symptoms, they measured inflammatory markers in the bloodstream, and they did cystoscopies before and after the 4 months that they were on lactoferrin. And this is what they found. Obviously, the symptoms improved dramatically. Inflammatory markers improved dramatically. Inflammation throughout the body dropped as measured in the bloodstream. But most importantly, those red inflamed bladders became pink and much, much healthier at the end of treatment. And Hunner's lesions almost completely healed. Like they couldn't see them in some of those patients. And in others, they were a tiny fraction. So almost completely healed, I think, was the quote in the study. This is the first time we have had a supplement, a simple over-the-counter supplement that's not made in a chemical lab. It comes from colostrum. Lactoferrin is the front line of our immune system. It is the most important ingredient in colostrum, which of course an infant needs when they're born, because it helps to build that infant's immune system. But lactoferrin in adults has been found to be quite helpful for a number of medical conditions. And so we had 2 years ago, this research team in Europe, they were able to demonstrate that lactoferrin could reduce recurring UTI. So again, for the people who are thinking they have an embedded infection, do lactoferrin, because lactoferrin, natural antibacterial, antifungal, antiviral. So again, this research team in Italy, they proved 2 years ago that lactoferrin was good at preventing recurring UTI, E. coli based. And then they did an IC study. They published the results in August. And the IC study was nothing short of astonishing, that 28 out of 31 had no symptoms afterwards. Their inflammatory markers decreased. The health of their bladder wall physically improved. It went from red and inflamed to pink, healthy, with Hunner's lesions disappearing or almost completely disappearing. So when that study came out, it's like, okay, now listen, now some people are going to say, hey, we want more research. Don't talk about this until there's more research. I take a very, very different viewpoint on that because, and I'm a pharmacologist. I spend all day doing research. The fact of the matter is that there are few options for IC patients who have Hunner's lesions. And as Cassidy said right here, she's tried cyclosporin, she's done other therapies. They haven't been particularly helpful. The lactoferrin study showed no side effects because it comes from milk. It comes from milk. And so to me, it's a no-brainer. And I know if I were in the shoes of somebody with Hunner's lesions, and if there isn't even a remote chance that this product might help improve these painful lesions, I don't know a patient who would say no to that unless they have a real issue with milk. So I would consider perhaps giving this a try. I just did a exhaustive blog post on this on the IC Network website. I go through all the research or the most relevant research. And we have sold out now twice in the IC Network shop. I've only brought in small amounts because I just wasn't sure what people would think. But we're already getting patients calling saying they're starting to feel better. They're not saying they're cured or healed yet, but we had one woman who for 10 years had gotten up every hour all night long, 3 weeks, a month on lactoferrin. She's now sleeping more than 3 hours at a time, and she's stunned. And she had severe Hunner's lesions. And she's going to have a hydrodistension in January to see where her bladder is. And that's going to be interesting to see if her bladder has improved. I suspect that it might start to show improvement based upon this study. Anne says, so you don't recommend a next generation urine test? Absolutely. No. I love the next generation DNA urine test. The reason why I love it is it's data, it's facts. It's facts. I mean, here's the problem. There are some patients out there who every time you have a flare, you self-medicate with antibiotics. Prove me wrong. I know some of you save your antibiotics. I know they're in the bedside table, and I know you're saving them just in case you have a flare. Almost every IC patient does that. Now, why do you feel better when you take an antibiotic? Because they have an anti-inflammatory effect. So you're getting basically a false positive. It's not actually helping kill bacteria, but it is making you feel better because it has a mild anti-inflammatory effect. But there are also some patients out there who refuse all therapy. They're like, hey, I don't care. Give me antibiotics. I don't believe you. This is infection. And I've worked with them. And my answer back to them is prove it. Listen, you've done antibiotics for 5 years. You're still struggling. Why? Maybe it's really not what you think it is. Because muscles can cause all those symptoms. They're like, I don't believe you. I don't believe you. I want antibiotics. And the doctor cuts them off and says, I'm not giving you any more antibiotics. We're done. You're damaging yourself. I had that patient call me, go, what do I do? My doctor's refusing antibiotics. My answer back to her was have a next generation DNA urine test. Prove him wrong. You have a next generation DNA urine test that comes back with a rare infection. You got all the ammunition you need to get a prescription for antibiotics, and you've got very essential drug resistance information. But if that next generation test comes back negative, you got to walk away from this belief that you have an embedded infection and or just an infection in general, because the next generation test will find everything. I'm going to sneeze. Hold on. Excuse me. Hi, Donna. Christine says, had to go out of town to receive my bladder instills. At least I'm able to receive them. Praise God. Pinky says, can you talk about trigonitis? Sure. So the trigone is a triangular piece of tissue that goes from ureter to ureter to the base of the bladder, right? So it's like this. And the trigone is different tissue. Don't ask me. It's either more estrogen receptors or something. Anyway, the trigone itself has a different cellular structure than the rest of your bladder. And so the other thing that makes the trigone interesting is that sometimes it can have a different appearance. Sometimes it gets bumpy. They call it a cobblestone effect, where it starts to look like a cobblestone street, a brick street. Now, some doctors in the past have believed that that was abnormal, and they would call that trigonitis, and they would laser it off. Others say, no, that's perfectly normal in that person, and it's not inflamed tissue. So trigonitis, gosh, you know what? We just don't hear. I haven't heard a study on trigonitis in a decade, maybe longer. It's just, I think we've moved beyond the concept of trigonitis. It's an old, from the 60s, 70s, 80s. So hold on a sec. Let me just take a look here. Let's see if I can find a recent study on it, and let's see. Nothing is popping up significantly. I'm not seeing anything this year. Let's see. So, trigonitis, some doctors believe inflammation of just the trigone area of the bladder. It can occur with changes in hormones. It can be related to an infection. It can be related to long-term use of a catheter or recurring UTI. Basically, just inflamed tissue. Yeah, but again, a lot of doctors are like, not that big of a deal. Others are like, maybe we should do something about it, like laser it off. Just doesn't come up at all. Here's one, Medscape. Trigonitis is a pathological process of the bladder trigone characterized by non-keratinizing squamous metaplasia, which is a growth of that tissue. It gets bumpy. Squamous metaplasia has been observed almost exclusively in women of childbearing age. It is non-existent in children. The condition usually occurs in response to an irritative insult to the trigone. Think of it maybe a kind of like as an internal rash. Patients can be asymptomatic. Patients can have some irritated voiding. It's considered benign, does not carry malignant potential. Yeah, I don't really see. I mean, you're inflamed. What are we going to do about it? I would follow the diet, try to figure out, I mean, if you have an indwelling catheter, that would explain a lot of tissue inflammation in the trigone. But again, I mean, some doctors just don't treat it. They don't consider it that big of a deal. Skin changes anyway with aging. I mean, if you're asymptomatic, but you've got a bumpy trigone, is it worth lasering off the trigone? No, of course not, because you're asymptomatic. Maybe that's just normal for you. Janelle says, yogurt gave me a flare, so could I take that as a milk product? Honey, the reason, there are a couple of different reasons why yogurt might have given you a flare. And no, lactoferrin would not trigger that same flare, because lactoferrin is just one part of that milk. Um, Number one, cultures. There are some patients who react to the probiotics in yogurt, and we've known that for years. And it took Gay Sandler, who's an author of an IC book, to help explain that for some people, certain species of probiotics trigger a histamine reaction. Like I switched to a different yogurt, a protein yogurt, last summer, and slowly over time, I could definitely tell it was bothering me, and so I went back to my original yogurt, which was Fage, and I'm perfectly fine with it. So not every yogurt has the same bacteria, and you could be reacting to the bacteria. The second thing that we want to think about is, are you reacting to the flavoring? You shouldn't be having lemon yogurt. You shouldn't be having coffee or chocolate yogurt. Stick to peach, unflavored, blueberry, things like that. And then, if you're lactose intolerant, that's a whole nother story. Not everybody's lactose intolerant. I usually don't, I didn't do dairy for a long time. I did coconut milk yogurt, and I was perfectly fine with coconut milk yogurt. It's just I can't do the saturated fat right now. So now I'm doing a 0-fat yogurt from Fage. So you're not the only one who's flared with yogurt, honey. I wouldn't worry at all about the lactoferrin triggering that same reaction, because the lactoferrin is not a bacteria that's going to trigger histamine. Lactoferrin is already in your body. It is in your tears. It is in your vaginal fluid. It is in all of your secretion. Lactoferrin is a frontline defense in our bodies. And so there's no reason to assume that the lactoferrin would trigger that same reaction. And the IC study found lactoferrin, the patients in the study had no side effects from it at all. Jeannie says, what do you think about suprapubic catheter being put in? I'm the one who is getting up 25 times a night. Botox took it down to 8 times a night. Next Botox has me self-catheterizing 13 times a day. I'm still up a lot at night. I can't cath as much as I need because of insurance and being sore. Doctor recommended a suprapubic catheter. Any thoughts? Well, honey, I mean, it's not a bad idea. It's not a bad idea in that it will give you a break. You wouldn't be the first patient to go to with extreme urinary frequency who decided to go the suprapubic catheter route just to try to have a break from having to run to the bathroom all the time. But that's not a viable long-term solution. You don't need artificial material in your body. I mean, they have that putting a catheter through your belly into your bladder involves incisions. It has to be maintained. Skin gets irritated. It's a short-term solution to try to get you to a better place so that you can try other things. But, our goal here really is to try to understand why you're urinating so much in the first place. You need a proper phenotyping, honey. Have you been phenotyped? Our guidelines say if the patient is not responding to treatment, just as you are not responding to treatment, we have to take a step back, revisit the diagnosis, and ask ourselves, what have we missed? Because if you're not getting better, they've missed something. You haven't. Well, maybe at the end of this meeting we can go into Zoom, and anybody who wants to come into Zoom, I can phenotype you there. It takes about 10 minutes to do. Very easy to do. Or you can call me this week, and I would be happy to do that. Okay. Jura says, I have IC bladder pain for many years, had mononucleosis. My next generation sequencing always comes back positive, but antibiotics takes years to get it down, but never gone completely. I had cyclosporin. My urologist would do a cystoscopy, but not under anesthesia. Should it be under anesthesia? Okay, so concept number one here is if you are consistently struggling with infection, which is rare in the IC patient population, but if you keep getting infection over and over and over again. We then have to ask, why is your body vulnerable to infection? What is it about your body that's making you more at risk for infection? So concept number one is just menopause, estrogen atrophy. The bladder defends itself with a really thick coating of mucus. If you don't have the mucus because your estrogen levels have dropped, because that's what happens, your body needs estrogen to make that protective lining in your bladder. If you're on birth control, if you're on Lupron, if you had a hysterectomy or you're just getting older, you don't have the estrogen anymore, which means you don't have the mucus anymore, or as much of it. That means that your bladder's ability to defend itself is now compromised. Okay, so basically without that thick coating of mucus, it's much easier for bacteria to attach to a cell and infect a cell. And so if you've had 2 bladder infections in 6 months, 3 in a year, you are in the recurring UTI category. In addition to antibiotics, they usually always also put you on a topical estrogen product to use vaginally so that we can improve that skin health and the skin's ability to resist infection. So concept number one is your age and estrogen level. Concept number two is there any chance you have an immune disorder? So I have a family member who literally got bladder infection after bladder infection after bladder infection. She also had sinus infection after sinus infection after sinus infection. Decades of this. And finally, when things got significantly worse and they did the correct testing, what they found is that she had no IgG. Her body was not producing immunoglobulins that your body uses to fight infection. She had none of the specific IgG. And that's why she was getting so many infections. So now she gets IgG infusions once a month. And finally, the infections are going down because it was about her body. And that disorder is called CVID. It's not COVID, it's called CVID. And it's kind of an age-related immune deficiency thing that happens to some patients, but not all. They suspect that it happens after toxic chemical exposures. But she believes that she was born with it. She believes that it goes way, way back. And I believe her 100%. 100%. Puts everything in context. So that's the other thing I would want to know is where are your IgG levels? Is your body having any trouble fighting infection? And now under the cystoscopy, listen, having a cystoscopy in the doctor's office should not be a problem. It should not be a problem because as long as they're not doing a hydrodistension, where you put water in the bladder and stretch the bladder wall, okay, that hurts. That's supposed to be done under anesthesia. But if your doctor just wants to do what I call a looky-loo, where they numb your urethra, stick a cystoscope in, take a look around, pull it out, you're done. That's a 5-minute test. I've had it done twice. If my doctor wanted to do it today, I'd say, sure, go for it. As long as they're not putting fluid in your bladder, it should not hurt. The only legacy of having a cystoscopy is the same legacy you have when you have a catheter put in. And that is your urethra gets jacked up and your urethra is annoyed for a few days. And the first time you pee after you have a catheter or a cystoscopy is not fun because that urethra has been stretched. That's why they numb the urethra with lidocaine first to make it easier to put in. But afterwards, your urethra says, hey, what the hell you do to me? And the first couple of times you pee, it's going to be uncomfortable, but it will go away. So if it's a simple looky-loo in the doctor's office, not worried about. I personally have had 2 of them. As long as they're not distending your bladder, putting a lot of fluid in your bladder, it would be fine. Now, I will say that I had somebody call me. She called me like 2 weeks ago, and her new doctor wanted to do a cystoscopy, but she didn't want to do it because her old doctor did it and it hurt. And she peed blood afterwards. Now, anytime you pee blood after a procedure like that, that means, and that's rare. That's so rare. Extremely rare. Like 0.0001% of that would normally happen. It is always possible that if they used a really big cystoscope, that it might tear the tissue a little bit. That might cause a little bit of blood. But if you've got super estrogen atrophy and your skin isn't particularly resilient, maybe that could maybe trigger a little tiny bit of blood. But for the most part, a simple cystoscopy in the doctor's office is a fairly easy procedure. It's the hydrodistension that's the hard part. Kayleen said she had a simple cystoscopy and it was traumatic. Well, a lot of it depends upon the doctor's skill level. A lot of it depends upon the equipment the doctor uses. Have they numbed your urethra properly? Have they prepped you properly? Have they explained what they're doing, et cetera, et cetera? Did they put something in it afterwards? You know, some doctors are known for putting like rescue installations in after cystoscopy to try to reduce any superficial irritation, but you could have a reaction to the rescue install. The value of a cystoscopy, and listen, I'm sorry, I'm giving mixed messages. Like, oh my God, I'm not giving mixed messages. Listen, girl, it's important that you let somebody look. Otherwise, you're forcing your doctor to guess. Now, what our AUA guidelines say, and the way the most IC doctors work, especially the top IC doctors, if you're a new patient and you go into clinic and you've got frequency urgency pressure pain, but if your urine comes out clear and there's no blood in your urine, they're going to go, okay, this might be estrogen atrophy. This might be this might be that. They usually are not going to do a cystoscopy. They're usually going to give you the diet, give you some meds, send you home for a couple of months and see how you do. And again, most patients do better once you put them on the diet and you give them a few basic meds or maybe a supplement. But if you were getting worse in that 3 months, or if you had a lot of blood in your urine, or if your pain levels were so severe that they literally have to look, it's important to let them look. Don't fear that information. That's valuable information. We had one patient who didn't let her doctor do a cystoscopy for years. And her symptoms got worse and worse and worse and worse and worse. And finally, out of desperation, she's like, okay, you can look, please look. Well, they found the problem. And she had a very simple bladder stone. It's basically a kidney stone that got too big that wouldn't pass through her urethra. And stones are sharp and painful. And the longer it was in there, the bigger it got. And it was as her urine was filling and as she was peeing, it was increasing, decreasing, decreasing. The stone was basically irritating her bladder wall and cutting her bladder wall, introducing bacteria into her bladder wall because stones are often covered with bacteria. So they broke it up, got it out of her, and guess what? She's cured. So she suffered needlessly for years for something that was completely treatable. So I think that if you haven't responded to treatment, if you feel like you're getting worse rather than better, if you've got more blood in your urine, or you just want to know, it's okay to have a cystoscopy. They do millions of them every year. And it's data, it's facts. And if that cystoscopy comes back normal, you got a normal bladder wall like I do, then you can now walk away from the concept of you having a bladder disease. Okay, you have a healthy bladder. But if that cystoscopy finds redness, lesions, ulcers, then that's also good too, because now we know we are treating a Hunner's lesion, and that's very different treatment. So our AUA guidelines say a cystoscopy or a hydrodistension with cystoscopy should be done if the diagnosis is in doubt. I just think it's important that you not force your doctors to guess. You deserve better than a guess. You deserve a fact. And so at some point in time, it's perfectly reasonable to let a doctor look briefly in your bladder just to see if there's a bladder stone in there. You never know. You never know. Jura says, I had every treatment in the IC guidelines. Nothing helps. It's embedded in bladder infection that I seem to have treatable. I mean, I have a negative next-gen test. Then, Jura, how do you know you have an embedded infection? I'm on menopause, but I had this since early adulthood, but good to know about estrogen. I only have a bladder infection. He wants to put water to see the bladder. Yeah, something they'll put a little bit of water in there just to kind of flush the bladder and look at it, but they're not stretching the bladder. Juris, again, why not give if you truly believe that you have an embedded infection, if you give your body lactoferrin, which has a strong antibacterial, antiviral, antifungal effect, that would be interesting. That would be an interesting experiment. But just remember that there isn't a single credible IC researcher out there in the last 30 years who have ever found an embedded infection. What we have found is that the overuse of antibiotics does cause the biome to change. It does cause a pathogenic lactobacillus to grow called Lactobacillus inners. And so despite them saying you have embedded infection, you need to long-term antibiotics, you got to understand that long-term antibiotics open up a whole nother can of worms. I did augmentin for 3 months under Dr. Paul Fugazzato. I had a drug-resistant Candida glabrata infection for 2 years after that. Yeah, and you think a bacterial infection hurts? I promise you, a fungal infection in your bladder, twice as bad. Twice as bad. The pain was off the charts. All because I took long-term antibiotics under the mistaken belief that I had an embedded UTI. But that's what we did back in the 90s. But we don't do that anymore. It's 2024. Now we phenotype. We want to find which group you fit in because each group has its own treatment. And so you need a proper phenotyping. So Juris, I mean, if you want to stick around, we can go into Zoom and we can talk about it in like an hour or so, or you can call me this week. I'm always happy to talk to you about it. And Christine said she had no Hunner's lesions this time after cystoscopy. She had lesions 6 years ago. Why would the pain be so bad without them? Thank you. Well, again, you need to be phenotyped, honey. So the legacy of an injury to the bladder wall is severe pain. So the way your body reacts to severe pain is it tightens your muscles. So here you've got a screaming ulcer in your bladder, and your muscles are just going to try to protect you, and they lock down tight because the guarding reflex stabilizes and holds that part of the body still so that the pain doesn't get worse. So now we've got lesions and we've got super tight muscles, but your lesions healed, but did your muscles release? They might not have. They might not have. I call it the chicken versus the egg dilemma. Which comes first, the chicken or the egg? And for us, it's which comes first, the bladder or the pelvic floor. They're both generally involved, but one is normally primary and one is normally secondary. And so let's say if you're a chemotherapy patient and the chemicals of the chemo damage your bladder, of course your bladder is going to scream in pain and your muscles will get tight to protect you from that pain. But once we stop the chemo and we stop the Mountain Dew or we stop the coffee or the green tea or the ketamine, we stop irritating the bladder. The goal here, we hope, is that these tight muscles will slowly release and get back to normal. But if you've been in pain for a long time, sometimes they get stuck there. It becomes habitual. And so now your bladder is healed, But the question is have your muscles also calmed down and healed? The second scenario, the far more likely scenario, are those patients whose symptoms began after a trauma. You fall on your tailbone. You were an athlete. You were raped. You had a difficult baby, a difficult childbirth. Now, of course, you don't know you fall down the stairs. You don't know you have a muscle injury. You've got all the symptoms of an infection. You call the doctor, hey, doc, I got an infection. Doctor goes, okay, do antibiotics. They don't work. You go back to the doc. Oh, let's do long-term antibiotics. Like I was saying this a while ago. They don't work. Then they try you on bladder meds. They don't work. And eventually you get the IC lecture. And the thing is you're so happy to have a diagnosis. You do everything they tell you to do. You take the low-dose antidepressants. You follow the IC diet. You take this. You take that. You do the bladder instill. But the problem is you still flare. Despite what you do, every single treatment you've done, they don't work. But now we know that. Now we know why. Bladder pain patients with muscle issues are not going to respond to a bladder treatment. Period. End of story. You can't keep chasing your symptoms. We have to focus on the underlying problem. And that is why every doctor is supposed to be assessing your pelvic floor at your very, very first appointment. And if your muscles are tight, you are to be immediately referred to a physical therapist. Every bladder treatment study at the National Institutes of Health and in other companies failed. They failed. They never got above placebo, maybe a couple percentage points. If you were lucky, 30% of patients who tried a bladder treatment might have gotten better. The study that was significantly better, the only study that was a true success at the National Institutes of Health was the pelvic floor physical therapy study. And in that study, 65, 70% of patients got better. And that was the moment the IC world was turned on its head, because that was the moment everybody went, uh-oh, how would physical therapy help a bladder disease? And especially when you consider the fact that most patients have a normal bladder, like I do. Oh, maybe actually IC is a muscle problem. Maybe it is. And now we know it is. And now we know everybody around the world, all the top doctors around the world recognize this. Patients with pelvic floor dysfunction have a muscle problem. Bladder treatments won't fix it. Muscle work will fix it. And then you have to throw in the widespread pain patients. The patients who have IC, IBS, vulvodynia, TMJ, migraines, fibro. You have very sensitive skin. You have a wicked sense of smell. You're in the widespread pain group like I am. And that's also an injury. That's an injury to your central nervous system. We now have a central nervous system that has become very, 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 very sensitive because of past injury or trauma. And in this case, what happens is because of that trauma, the central nervous system starts to amplify the pain. And it makes the pain higher and higher and higher throughout your entire body. And again, for these patients, bladder treatments are pointless. And we have a brand new study that shows that. If you have systemic pain, widespread pain, if you have anxiety disorder, our treatment now is completely different, because we're going to focus completely on widespread pain, the central nervous system. And there's just no reason for you to put thousands of dollars into bladder treatments if you've got widespread pain. What we've got to do instead is get your brain to calm its ass down. We got to calm the entire central nervous system down. We've got to get you out of fight or flight, because patients with widespread pain are stuck in fight or flight. And that's why y'all have anxiety disorder. That's why I had such severe anxiety disorder when I was in my 20s and 30s. And I still have anxiety disorder today. It's much, much, much better. It's a fraction of what it was. All right. Anne said, and guys, Facebook, sorry, honey, I'm looking at all of them, but let's just hit YouTube one more time, one or two more times, then we'll come back to Facebook. Anne said, last week you mentioned your rectal spasms. What causes them? I've had spasms after a bowel movement all my life. I thought they were from endometrial adhesions. Well, they could be from endometrial adhesions, but let me get this book here. Hold on. So there is a condition called proctalgia fugax, and it's basically a violent bowel spasm that suddenly occurs, lasts for anywhere from a couple minutes to maybe 20 minutes, and then it just miraculously goes away, and there's no rhyme or reason to it. And so it was actually Jerome Weiss in this book, Breaking Through Chronic Pelvic Pain, that explained it the best. So let me see if I can get this for you. Here it is. Okay, I need my reading glasses. Hold on. I've got my computer. Oh, getting older. My eyes are so freaking weird right now. Okay, sorry, I have to put the book away because I got my computer glasses on. Okay, the term proctalgia fugax may sound somewhat comical, but believe me, the problem it designates does not make the sufferers laugh. Proctalgia, and let's see, proctalgia is a Greek derivative that denotes pain in the anorectal area. Thankfully, the word fugax means fleeting, comes and goes. When you experience a stunningly deep anorectal pain, fleeting is what you pray for, and wiped out is how you are likely to feel when it ends. The upside is that proctalgia fugax attacks are usually brief, and they generally subside as one gets older, rarely occurring after the age of 70. In 2006, an international group of gastroenterologists gathered in Rome to collect scientific data that would help physicians diagnose, classify, and treat functional gastrointestinal disorders. They concluded that to make a diagnosis of proctalgia fugax, 3 symptoms must be present: recurring episodes of pain localized to the anus or lower rectum, episodes that last from seconds to minutes, and an absence of rectal pain between episodes. An estimated 14% of the population has this disorder, though the incidence may be much higher in those with GI problems. Furthermore, because the attacks are sporadic and quickly and completely resolve, many who experience them may not seek medical care. This leads me to suspect that 14% may be an underestimation. Proctalgia fugax attacks come on suddenly with only a brief premonition that one might be coming on, and during an attack, one may be completely incapacitated and unable to move. While generally the severe spasm lasts from seconds to 5 minutes or so, some patients have reported episodes lasting 10 minutes or longer. They're sporadic. They recur at unpredictable intervals from weeks to months and at any time, day or night. Patients have compared the pain's intensity to that of natural childbirth, kidney stones, or gallbladder attacks. As for the quality of the pain, descriptions run the gamut from cramping, gnawing, sickening to, quote, like a sharp object piercing the rectum, or like a sensation of being squeezed in a vice. So what causes it? It is so in the section, what causes proctalgia fugax? Let's see, hold on. The mainstream medical community considers proctalgia fugax to be a poorly understood benign disorder of the GI tract that can be controlled with meds. However, based on my clinical findings over the years, I feel comfortable declaring pudendal neuralgia and a spasm trigger points of the pelvic floor, especially the puborectalis muscle, to be the clear cause of this rectal pain. So an interesting study conducted in Japan supports the pudendal nerve cause. Dr. Takano reports that in almost all of the 68 proctalgia fugax patients, a point of tenderness was found corresponding to the pudendal nerve. The nature of the pain caused by pressing the point was recognized by patients as similar to that experienced in the attack. He indicates that blocking the nerve at the point of tenderness eliminated the spasmodic attacks completely in most patients. So what triggers these attacks? Sitting for long periods, sexual intercourse or masturbation, extreme stress and anxiety, extreme physical exhaustion, constipation and straining with bowel movements, and IBS. Okay. And then there's a whole story in here of somebody. Anyway, get this book. You have proctalgia fugax, get this book. So, because I have had tight pelvic floor muscles on my left side for many, many years, because of my SI joint, all of my nerves in my pelvis are much more sensitive. And in fact, I have a little, a kind of sharp little pain right now, right at my SI joint in my left, kind of, well, it's kind of the piriformis muscle. Yeah, it's right there. Okay. So I feel, and you guys just bear with me because, you know, I have no embarrassment. I will talk about anything, no shame. I feel anything in my rectum, anything. If there is even a little tiny piece of stool the size of a sunflower seed, I feel it, and it annoys me. My skin is very sensitive inside my rectum. And what has helped tremendously is physical therapy to release the muscles and doing things that calm nerves down. And that's going to be like using Anacream, ANECREAM, or using hemorrhoid suppositories, which reduce inflammation in the rectum. I can only remember, you know, I had IBS, really bad IBS in my 20s for years, and I just really, it's just bowel movements were just painful for years and years and years. And I can remember that when I finally got the IBS under control and changed my diet and got soluble fiber in there, I distinctly remember the first time I had a normal urge to have a bowel movement. I went to the bathroom, I did my thing, and then after I was done, I was like, wait, that didn't hurt. It didn't hurt. So I got to work on the muscles, got to work on the nerves. And also I found that a lot of what was irritating my rectum was insoluble fibers like granola, things that were sharps. You know, for IBS, we want to make sure you have a good intake of fiber, but we want to do soluble fiber rather than insoluble fiber. Insoluble fiber has rough edges, which irritate the bowel as it's coming out of you. And when you've got a lot of sensitive nerves in your rectum, believe me, you feel all that. So I don't do things like granola at all. Yikes. No. Jennifer is going to go see Dr. Eckenberg. Awesome. Christine said, can my urologist refer you physical therapy? Absolutely. All right, let's come back to Facebook here. Mary says, okay, here, hold on. Boy, you guys have been busy here on Facebook. I'm sorry. Sorry. Hold on. I'm trying to get to the back. Okay. Katie said, I've learned so much from your master classes on YouTube. Thank you. Still processing it because I have the feeling that we are 10 years behind in Europe with IC treatments. You give a tip not to drive immediately home after a bladder install. I'm curious what the reason is. Honey, because it hurts. It hurts. The last thing you want to do is drive home with DMSO in your bladder. It hurts. God forbid you get stuck in a traffic jam. No. It's always better to sit at your doctor's office for 30 minutes, your dwell time, pee it out, then go home. And that's from personal experience. I did drive home with DMSO in my bladder, and I paid a terrible price for it. That pain was insane. Mary said, God forbid you get in a car accident or you get pulled over by the police. Oh, my God. Mary said, how do you test for IgG? It's a blood test, honey. Kayleen said her cystoscopy was bad because her doctor put too much fluid in too fast. Yeah, that can happen. Lori said, can your tailbone hurt or be sore with an icy bladder? Absolutely. And usually it's the tailbone that's the underlying problem that's victimizing the bladder. Lori, I have a really good blog on our website about tailbone injuries and IC, and it's in our magazine also. Tailbone injuries are very, very common onset for all the symptoms related to IC. And that is because the tailbone is not passive, the tailbone is active. There are a lot of muscles that attach to the tailbone. Let me get my model here. Where is it? Where is my model? Okay, got it. What did I do with it? Is it there? Nope. Oh, I know where it is. Hold on. I know where it is. I was FaceTiming a patient while sitting in another room. Here, hold on a sec. Bear with me, you guys on YouTube. I need to fix your mic. You're gonna hear noises. Okay. Is that better? That's better. Okay. So getting back to the tailbone here. So just to introduce you to your pelvis here for a moment. So here's the front of your pelvis. Hip bone, pubic bone. Let's turn it around. Vertebrae, sacrum, tailbone. And what I want you to see here is that your tailbone is not passive. Your tailbone is actually the foundation of your pelvis. And you've got muscles that go to the left and you've got muscles that go to the right. And so when you hurt your tailbone, you hurt the corresponding muscles and nerves. And so we now realize that tailbone injuries are a well-known underlying cause of all the pelvic floor dysfunction that then eventually leads to bladder pain in many, many patients. Many patients have a history of tailbone injuries. I fell and broke my tailbone in 8th grade, and that's when my frequency urgency first started. I broke the tip of my tailbone off completely. So imagine what that did. Imagine what that did to the muscles that attach to that small tip of my tailbone. Joni said, I had urethra pain, pelvic floor burning for almost a year, recently developed hives on legs, antihistamines, which also seem to help. Is there any other test to request to see if there's a relationship? Yes. Dr. Curtis Nickel actually, in his proposal for 9 phenotypes for IC last year, or in 2022, whichever, was it last year? Okay, well, anyway, he believes that there are 9 distinct patient groups in the IC patient population. One of those groups, he believes, is an allergenic group. And that if you flare during allergy season, if you flare when the Santa Ana winds are blowing, then that suggests that you could have a mast cell disorder. You could have, or an allergenic disorder of some type. And so the way he told doctors to look for that is to gently poke the bladder wall with a cystoscope. Just, poke it. And if by poking it, you end up with what they call a mucosal wheal, which is basically a little red spot, he said that's a sign that you're dealing with a patient who has an allergenic origin. And these are the patients that you would want to give antihistamines to. Okay, so that's, I mean, the other test they could do is they could biopsy your bladder to look for an abundance of mast cells, but that's much more aggressive and that's going to leave scar tissue and be much more uncomfortable. I think it's very, very important that you watch our video on phenotyping because it may be incidental. If you're, if you've had a hysterectomy, if you're in your 40s, 50s, 60s, the very, very first thing we have to look for is the quality and health of your skin and estrogen atrophy, because estrogen atrophy affects your bladder wall too. Okay, and so aging matters. The reason why your bladder might be more vulnerable isn't that you're necessarily allergenic, it's that you don't have the mucus that normally protect the mast cells in your bladder. And that's because of aging. How old are you, Joni? And I'm sorry, I know that you asked this question 20 minutes ago. I hope you're still here. Amy said, I've been diagnosed with IC, but I have chronic UTIs. In the last 12 months, I've had 9 UAs and only 2 have come back negative. They say I need to be on SAT. Nothing works though. It will help for 3 to 4 weeks. I will go take a UA. It will be positive. I had a hysterectomy at 27. Wow. So they just added estrogen cream to my antibiotic regimen. I take tons of probiotics and colostrum. I'm desperate as well. Okay. So Amy, number one, I'm shocked that you're just going on estrogen now. Because when you look at so what the recurring UTI research found, and I attended a lecture years ago taught by Dr. Anthony Schaefer at a National Institutes of Health meeting on recurring UTI. Okay. And what they did is they studied the urine, the vaginal secretions, the skin, whatever, of every patient in the study every single day. And here's what they found. 24 hours before the bacteria arrived in the bladder, it was living in the vagina quite happily. And that then led the researchers to ask, well, what's happened to our vaginal defenses? Why has the vagina become a safe haven for bacteria? And the answer goes right back to estrogen atrophy. That the vagina is struggling to defend itself too, because it also doesn't have that nice thick coating of mucus because of the loss of estrogen. And so they said that what we would normally do is give that woman vaginal estrogen cream to improve the quality and health of her skin at the same time that we're going to give her antibiotics. But now also we have next generation DNA urine testing, because the other thing, if you were on the phone with me, I would want to know, what bacteria are they finding specifically? Are they just telling you you have a bladder infection? Or are they saying it's E. coli or staph or strep or enterococcus? If it's the same bacteria over and over and over again, like E. coli, then that means that you either have a very, very drug-resistant form of E. coli. And I will tell you, E. coli is fascinating. There's a fabulous researcher named Scott Holmgren who has been studying E. coli for many years now. And what E. coli does in the face of a threat like antibiotics is it changes shape. It goes from being round to being a noodle. And when it's in the noodle shape, the white blood cells don't recognize it. So the white blood cells don't kill it. Now, I haven't looked at his research in the last year or two. I will just tell you his research is nothing short of astonishing, and E. coli is nothing short of astonishing. It's a very, very robust bacteria. So again, do you have a super drug-resistant form of E. coli, or are you being inoculated with E. coli in your home in some way? Is there a reservoir of E. coli in your home? And the very first place that we would look is actually in a bathtub with jets. So, you know, it's wonderful to be in a bathtub with jets and you get hot water and the bubbles are blowing and makes you feel good. But if the jets are installed incorrectly, the water doesn't drain out. And so what happens is you end up with this super, super contaminated water inside each jet. When you turn it on, it just floods water with bacteria. So those jets have to be installed slightly pointed downward so that all the water drops down. If it's this way, if it's level, or if it's like this, it's going to become a bacteria factory. So that would be something else. So to me, if I were in your shoes, I would, number one, be asking for a next generation DNA urine test. I want to know what drug resistancies you've got going on, because it may be that some of the antibiotics you've been given have no chance of killing this infection. It may be drug resistant to it. You know, and again, we have lactoferrin research from 2 years ago that showed that lactoferrin was good. You're on the colostrum, but maybe just going straight to lactoferrin, just to get a concentrated dose of lactoferrin, might be better. That study, the recurring UTI lactoferrin study, was 1,000 milligrams a day for 7 days, 400 milligrams a day for 2 weeks, 200 milligrams a day for 2 months. So it may be that maybe your dosing is a little bit low, maybe, but it's a good study. It's a solid study. And you guys, please remember, I'm not a doctor. I can't give you medical advice. That's never my place. My job is to get you and your doctor closer and with a new set of questions. I want to open new doors for you. And so that next generation test could potentially open brand new doors of treatment. And then in the meantime, the lactoferrin research, you can show it to your doctor, is solid research. There's a blog on our website right now, icnetwork.org. You can print it out, take it to your doctor. That's got the link to the research. You can print out the research, the recurring E. coli infection research. Say, hey, what do you think? Do you see any harm in me trying this? Anne says, is hip bursitis related to pelvic floor? Yes, it certainly could be. Penny, what is the treatment for anxiety disorder? I have a great video on our website in my Living with IC video series. It is techniques that will bring you out of fight or flight. And if you want to call me this week, I can walk you through some over the phone. Or you can watch the video. Lori says, I have SI joints issues also. Will that cause issues with IC bladder? Yes, it will. So what do you do for your SI joint issues? Well, that gets tricky. My SI joint is too mobile. Let me show you guys a picture of the SI joint. So the SI joint, the sacroiliac joint, is right here. It is the joint which connects the sacrum with the hip bone, So we've got an SI joint on the left and the SI joint on the right. This joint is supposed to be stiff. It is not supposed to move much, but some of us are hypermobile. My left is hypermobile, and my doc told me it is the most common injury of tennis players. And when I was in my 20s, I was actually a professional tennis player for a brief period of time before I went back to grad school. I loved playing tennis. I miss it terribly. But it turns out if you're right-handed, you put all your weight on your left foot when you're swinging a racket, and then you're twisting your body on that joint, you cause SI issues. So SI dysfunction is the #1 injury that we see in long-term tennis players like me. So what can we do about it? I wear an SI belt. I would like every now and then when it hurts, sometimes I have to manipulate, sometimes it dislocates. Normally your joint is like this, but sometimes it slips like this. And believe me, that hurts like hell. And you have to lay on your couch on your belly and with the one side off and pull it back out. I've done that many times. It hurts. But there's something called prolotherapy, and prolotherapy is where they inject something into a ligament that will kind of reset everything, and that's what I want to do. But my physiatrist and my orthopedic surgeon are both clueless. Their only response to that is it's going to bleed a lot. And it's like, yeah, am I going to have SI dysfunction the rest of my life? I mean, because it's gotten worse as I've gotten older, and it has, and so having a hypermobile SI joint, the piriformis muscle and the muscles up there that normally stabilize that joint lock down harder to try to hold the joint in place. And that's why my muscles on my left side are always tight. No matter what I do, I mean, I can use my wand and I can relax them, but the next day they'll be tight again because that joint's just moving way too much. So you need to have a good talk with a physiatrist. I get steroid injections into my SI joint also. Are they helpful? Not really. I've had 3, including like 2 months ago, I had one. And if you've never seen it, let me go get an SI belt so that you can see what that is. Hold on a sec. Super easy. Okay. So this is the first SI belt I bought. My doctor said, go get an SI belt. See if you wrap the joint, you wrap your hip and stabilize if the pain will go away. And it did immediately. And so you basically put it right here and you put it under your pants, right? And so you can see it's right at the SI level. But it's big, and it used to. I mean, I've lost a lot of weight this year, but so it doesn't happen quite so much. But I used to hate where the fat pops out above it. You know what I mean? You know what I mean? I like this blue one better. These are both on Amazon because you can wear it over pants, and I wear it like if I were wearing a long sweater, I would just, wear it like this, and nobody has a clue. So I still wear these every now and then. All right. Lori says, can I call you? Can you call me this week? Absolutely. I will be here all week. I am, I'll be here all week for sure. Renee said her tailbone injury started a problem also in 7th grade at a car wreck, to being slammed against the driver's side, then 3 C-sections with scarring. Pelvic therapy helped me the most. I do take hydroxyzine for mast cell regulation. Okay, good. I'm glad the physical therapy is working for you. And she also says estrogen cream has worked miracles for her. It does for many. Joni says she's 68. She's on topical estrogen now for about 6 months. Girl, you should have been on estrogen 10 years ago. I mean, when did you have your hysterectomy? Did you say you had your hysterectomy at 24? And please know, Mary's asking Joni, did estrogen cream burn? Yes, estrogen cream will burn if your skin is very, very dry. But the burning will go away. You have to ride through the burn. Not everybody burns, but people who are very, very dry will burn no matter what you put on their skin. But every time you give that skin estrogen, it plumps up and starts to produce mucus. So the burning generally resolves after a couple of weeks. If the burning does not resolve, then maybe you're using Premarin which has alcohol in it. It's a preservative that can cause extra burning. So we usually don't recommend brand names. We go for a compounded preservative-free formula. Renee said, is it possible that a repeat UTI is from a biofilm? Honey, biofilms are not... Biofilms are everywhere. Biofilms are on our skin. Biofilms are in streams. Biofilms are in the ocean. Bacteria live together in biofilms. It's not like biofilms only happen when you have a pathogenic infection. Biofilms are fascinating because what happens is groups of bacteria come together to live together. And they actually arrange themselves in a very, very specific way. So biofilms kind of have rings in them with certain bacteria in the middle and then bacteria around it. And then, I mean, it's fascinating the way a biofilm grows. And then they secrete a kind of wax-like coating together over the top of it. But they can move. You know, they crawl. It's kind of like a turtle under a shell in a way. Eventually, though, they consume all of the food within the biofilm. And once there's no more food, the biofilm breaks open and they all go on their way, look for more bacteria, create another bacterial colony somewhere else. We have research that has watched biofilms travel from outside a catheter, up the catheter, through the urethra, and into the bladder. So biofilms are a normal and natural way the bacteria survive. The challenge with biofilms is that they're very hard to break through. And there are a lot of companies out there now marketing their biofilm busting supplements. But here's the problem, is that biofilms are good in a way because they keep bacteria in one place. They control their movement to a certain extent. And when you break open a biofilm, they all disperse. And they're going to go lots of places. But here's the deal. They have found bacteria commonly in your mouth, in your brain, living in biofilms. Okay. And don't ask me the source of that. That was like 10 years ago. The worry is that if you take something which breaks open all the biofilms at one time, you're basically flooding your entire body with this vast amount of very, very diverse bacteria, some good, some bad. And the concern is if you happen to have a biofilm in your brain, are you going to pop it open and now distribute all this infectious material deep inside your brain? So there's a lot of research, don't believe those companies who are saying you all have biofilms and you all need to take our product to break open the biofilms. We just don't know the long-term ramifications and safety of that. Now, I'm going to admit that I haven't read about biofilms in probably 5 years, since before COVID. So has something changed? Possibly. Donna says, how do you feel about trigger point injections into the pelvic floor through the vagina? I've had 2. I think that if you've got a tight trigger point down there, it's very important that they try to manipulate that trigger point, and doing a trigger point injection to numb it so that they can physically manipulate it makes total sense. I've had 2 or 3 nerve blocks and various injections through my vaginal wall myself. Anne says, thank you, Jill. From your store, I got the Breaking Through Chronic Pelvic Pain book, and I'm learning a lot. I haven't gotten to that page yet, so thank you. Doctor added Solu-Cortef to add the other installation with diaphragmatic breathing. Okay. Normally, Solu-Cortef is in every installation. I'm surprised it's only every other. It's a very common ingredient in rescue instills, but every doctor has their own formula. Lori says, I've been praying for you. Thank you, honey. Boy, I've really felt the prayers. I've been trying to write my Christmas letter. How do I explain? Last year at this time, my Christmas letter talked about my parents dying. This year, I don't want my Christmas letter to talk about breast cancer, but it's like, yikes. So I think my Christmas letter this year is just going to be about gratitude and saying thank you to people who prayed for me because it's been a rough year. I had a bladder lift 10 years ago. They used mesh, which was not intended for the bladder. I keep being told I have IC. Do you think they can remove the mesh? Lori, I hope that you're participating in the lawsuits. There are a lot of lawsuits going out right now about that mesh. Depending upon the type of mesh you used and the company they got it from, patients have gotten millions of dollars because they used mesh that was never meant to be used in the human body. There are some very, very good documentaries on this. I would encourage you to watch them. They're shocking that a company that was marketing mesh for things like bladder lifts, they were cut off by the mesh manufacturer here in the United States and the mesh manufacturer said, this is not meant to be used inside the human body. This is polypropylene. And the problem with this polypropylene mesh, if that's what you had, is that it migrates. It moves through tissue. And it starts out like this white netting and it becomes black, crumpled, and covered with bacteria. And there was just yet another study about this, God, in the last month that talks specifically about the infections on mesh. Hold on, let me see if I can find that. Hold on, let me see if I can find that because it was fascinating. Mesh bacteria. Here it is. Yeah, that like literally just crossed my desk in the last month or two. Let me see if I can find this. Where was that? There are lots of different types of mesh, but it's really the polypropylene. Here, hold on. Let me see if I can, God, there's a lot of research on lots of different types of meshes, right, that have been published in the last couple months. Hold on. Let me just. Management of mesh complications. Oh, here, okay. November 2024. Despite the reputation of sacrocolpoplexy as a highly durable reconstructive surgery for pelvic organ prolapse, mesh-related complications remain a significant deterrent for patients. Okay, here they found mesh complications include vaginal mesh exposure, bladder or bowel erosions, inflammatory or infectious conditions, and mesh-related pain. Presentation ranged from overt symptoms such as mesh palpation in the vagina to an insidious-like infection manifesting as back pain and malaise. Okay, for patients with vaginal exposure, they encourage removal of the entire mesh arm via an abdominal approach. However, many prefer to utilize a transvaginal or partial excisional approach first. The infection is managed with long-term antibiotics and often requires mesh removal. That prevention strategies include using a lightweight polypropylene mesh attached to well vascularized vaginal walls, avoiding direct placement on any sutured vaginal or bladder. Well, anyway, we don't need to read that. See, I was right. It did cross my desk. Okay. So, and that was published November 24 in the International Journal of Urogynecology. So, getting back to your question, do you think they can remove the mesh? There are some really good mesh support groups online, and I think you need to talk with other patients. I will tell you that from the patients that I've worked with, they have been able to get it removed, but it's a beast of a surgery. And it depends upon where the mesh is, what the mesh is attached to, et cetera, et cetera. And so that's why I think it's really, really important for you to know about the lawsuits, because I mean, like there's this big movement in the United Kingdom because it was used in the United Kingdom, and patients really organized over there and did a lot of this seminal research, and they were able to get it removed, or certain types of mesh get it removed from surgical use, but only after many women had been harmed. And some were harmed with removal. So you deserve to be compensated for that. Google vaginal mesh documentaries and watch. There are a couple out there. Watch them. You can get a little bit more information about this, but more importantly, you can see what the companies did to make this so much worse. You know, like in the case of the company, and I don't remember their name, where the U.S. manufacturer banned them. They went to China, and they got it from China. From this, so the documentary people went to China, and they found this filthy, tiny building, which quote unquote was the manufacturer of this mesh. The American manufacturer then, to even get it into the United States, had to change the labels on all the boxes. They lied. They knew if they kept that label on it, they would not allow it to be imported. So they deliberately changed the labeling to get it into the United States. Then when it got to the United States, they did the testing on it, and it did not test the same. There were issues with the testing, and yet they bought, like, if I remember correctly, like 20 years of it, like a massive amount of this mesh from a questionable source in China. So watch I think 60 Minutes did a documentary. I think Frontline did a documentary. Watch several of those documentaries. Okay. Mary says, how do they test for IgG? It's a blood test, honey. Renee says her right SI is hypermobile. Yep. Amy says, I also have IBS, non-infectious gastroenteritis, colitis. It is almost always E. coli. On one or two occasions, it's been positive for E. coli and another form of bacteria. I've also asked for pelvic floor therapy and been told there's no one qualified in our area, and I suffer from anxiety as well. So, Amy, call me. Call me. Let's talk. So I have access to a very good database, pelvicrehab.com. You can all use that. That's a great place to go look for a physical therapist who's been trained correctly in the physical therapy that we're talking about. This is internal physical therapy. If you go to a physical therapist and they refuse to do internal, they refuse to do an internal exam, they're not trained. This is internal therapy. The only way that you can touch these muscles is with a finger inside your vagina or your rectum if you're a man. You can't reach them as easily from the outside. And remember, down here, there's a bunch of fat in your butt. So they're not going to be able to reach these easily. The finger in the vagina is the easiest way to check the health of these muscles. And it's fascinating. It is fascinating because I call it the hallelujah moment. When you go to a physical therapist for the first time, couple of tips. Number one, your ability to describe your symptoms gives them a roadmap. So you don't just walk in and say, hey, I have IC. They told me to get a pelvic assessment. Don't say that. You got to describe your symptoms. Hey, when I try to urinate, I have to wait 5 or 10 seconds before I can release urine. Or, hey, I've got pain on my left side or pain on my right side. Or I have pain that shoots down my leg. Anything and everything is relevant, even the weird random symptoms that you might get, like a buzzing, like I have now a vibration in my left butt cheek, which is what I get if I sit too long. And that's all related to my SI joint. But things like that are important. Do you have pins and needles, areas of numbness? Where's your pain located? Is it on the left? Is it on the right? Is it shallow? Is it deep? Okay. So when you go there, your ability to describe these symptoms is everything because you're giving them a roadmap. They will usually have you walk up and down a hallway. We want to see how you walk. Are you bow-legged? Are you duck-footed? You have one leg longer than the other where your pelvis is tilted. That's going to take a toll on your muscles over time. When you're young, your body's not going to notice it. But once you're in your 30s, if you've been walking like this for your whole life, eventually that's going to affect your pelvic floor and create problems with your pelvic floor. If you're going to the gym and you're doing a Stairmaster, boom, 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 boom to your pelvis, that's a problem. That's going to stress your pelvic floor. Okay. After they do the external exam, they're going to ask if they can do an internal exam. Do it. It's so easy and it's fascinating. You're not in stirrups, nothing like that. All you're going to do is be laying flat on a physical therapy table with a blanket over you. You'll have your knees up a little bit. They're going to insert their finger, right? And they're going to touch shallow muscles. They're going to be on the left side. Then they're going to be on the right side. They're going to go shallow, mid-level muscle, and deep muscle. And if they can touch a muscle and trigger pain, that is what I call your hallelujah moment. That's exciting. It's like, that's it. What are you touching? And hopefully they'll say, oh, that's your piriformis muscle on your left side, or that's your obturator, or that's your levator ani. If you have shallow pain, like pain around your rectum, pain around your urethra, those are your shallow muscles. Those are your levator ani. If you've got a pain that's deeper, especially up around your SI joint, that's probably your piriformis. And so the goal here after that pelvic floor assessment is to walk out of that appointment with the name of the muscle that's the problem so that you can now do some research to learn how to deal with it. Hopefully they will give you some things that you can do at home, but we want you to go back to physical therapy now because internal pelvic floor a massage is the single quickest, easiest way to deal with it. I've had it done many times. There's no reason to fear it. Super easy. The question that you have to ask your physical therapist after 3 or 4 visits is, are my muscles responding to therapy, or are my muscles always locking back down to tension? Like my muscles on my left side, no matter what they do, always lock back down into tension. If that happens, then we have to step away from muscles for a moment, and we have to look at the things that put stress on muscles, also known as your bones. Your bones. So for me, it's my SI joint, but you could have a funky hip, you could have a funky SI joint, you could have a broken tailbone, because again, look at everything that attaches to the tailbone. So if you have a tailbone issue, that's going to affect all these muscles, all in this area. That can be a problem. It could be a bad knee if you're limping. But for many people, actually, it's how their foot hits the ground. It often goes to their feet. Like I worked with 2 men in the last week who were both very, very bow-legged. I mean, severely bow-legged. And when you're bow-legged, you know, your knees are going out. It's like you're walking like you're on a horse, right? So you're walking like this. And their feet, instead of being level, they're often walking on the outside of their feet. And then that's a problem, because all those forces and stresses go right up the legs, right into the pelvic floor, and they cause tension. If you're bow-legged on one side, not the other, or just if there's an imbalance. The goal here, you have to remember, is your hips need to be level. And your hips are not going to be level if you've got one leg longer than the other, or we've got a problem with your feet. And so it is, again, this book, this is the bomb, guy. This is the book. This is the book that taught me everything. Dr. Jerome Weiss, the first urologist who 30 years ago figured out bladder treatments didn't work, and he became a master at all things pelvic floor. National leader. And honestly, he was ignored for 20 years by other doctors, but now everybody knows he was correct. And his chapter on the feet is fascinating. You can see I've highlighted lots, you know, the great section, you know, just if you're curious. This is a map of the pudendal nerve. When we think pudendal nerve entrapment, the nerve comes, I don't know if you can see this here. Here is the spine. The nerve is coming off the spine, and it actually weaves through the muscle. So the nerves come off the spine in several locations, and they come into one group, one structure, and then they go through this little tiny canal called the Alcock's Canal. And then once they leave the Alcock's Canal, they split up again, and they innervate the urethra all the way to the rectum, right? Clitoris, etc. So pudendal nerve entrapments mean that the muscle in this area is squeezing the nerve somewhere in this area. But let me just show you the chapter on les feet. Here it is right here. This is one of my favorite pictures. This is a fantastic picture to show you. So this leg right here is a perfect leg, 90-degree angle from the ground. Goes straight up, and then it bows out slightly as the femur connects to the hip bone, right? But look at what happens if you have an ankle that rolls inward. If you have an ankle that rolls inward, and I will tell you, my dad had a torn ligament in the last few years of his life, and his ankle rolled in terribly. So you immediately lose your 90-degree angle. So now your shin bone, you know, is like at a 20-degree, well, no, it's probably like a 75-degree angle from the ground. And that angle is exaggerated in the femur. And if you look up close, look at the piriformis muscle on that side is massively stretched out compared to the muscle on this side. You see that? Look at that tight muscle right there. That's all from an ankle that rolls inward. So again, if your muscles are not responding to therapy, if you're getting and they're staying tight all the time, then we have to look at your feet also. That became the final mystery that he solved in the last 15 years of his career. So he wanted to know why muscles stayed tight. And very humble guy. He learned from everybody. He went everywhere. You know, I mean, if you could have met him, lovely, lovely man, very kind. And it was finally spending time with a podiatrist that taught him the foot connection. This is another important diagram, because this is a bicycle seat. And if you look close, you can see that the bicycle seat pushes directly up against the clitoral and penile branch of the nerve right here. So see, you have the nerves that come off the spine. And if you're sitting on a bike for a long period of time, you're running the risk of bike rider syndrome. That's pushing right up. Fascinating, don't you think? I think the whole thing's fascinating. Lori says, what is lactoferrin? Lactoferrin is a protein found in colostrum in mother's milk. It is considered the frontline defense of our immune system. Lacto stands for milk, ferrin stands for iron, because the way lactoferrin works is it binds iron molecules so that bacteria cannot use them to grow. We have lactoferrin throughout our body. It's in all of our secretions. It's in your tears right now. It's in your saliva. It's in your vaginal fluid or seminal fluid. Lactoferrin is one of the most important proteins found in colostrum and mother's milk because it helps to build the baby's immune system. But lactoferrin is also used by adults. You know, the challenge is as we get older, our lactoferrin levels drop in some ways. And I don't understand that mechanism exactly. I don't know if it's gradual or not, but what they have found in research studies, and many research studies, that with adults with a variety of health conditions, when you give them lactoferrin, their immune system becomes stronger. It gets boosted. So we've got research with lactoferrin with lots of different medical conditions, including recurring UTIs and including interstitial cystitis. And the IC study came out last August. There's a blog on our website, right on our front page, which goes through all of that research. 28 out of 31 patients after treatment with lactoferrin had no symptoms. Their flares were gone. Their bladders had gone from red and irritated and inflamed to pink and normal. Hunner's lesions almost completely disappeared. Inflammatory markers dropped. And again, this is very, very new. So lactoferrin now, I think, is becoming a very, very important option for patients with Hunner's lesions and patients with a lot of inflammation. Because I am a breast cancer patient, even though I had surgery and technically they got it all, there is even research with lactoferrin and cancer and how it helps to prevent cancer from growing. And so as I was doing my research and my due diligence to understand it more before I talked to you guys about it, I was literally going through all the research going, Jill, why aren't you on this? And so I'm on it now too. You know, I'm very, very focused on wanting to heal and get better. And anything that we can do to bring inflammation down in our body, I think is important. I'm redoing our diet guide right now, and our free diet guide. And I'm putting in the foods that are known for causing more inflammation and how important it is that we try to reduce those, like a lot of sugar. I don't eat candy. I don't eat a lot of sweets per se, which is, I think, good. And the other thing that I'm doing is I'm putting in the latest research on the chemicals found in American food that are known for causing cancer and other inflammatory issues and endocrine mimickers. You know, I'm like totally stunned at many of the connections are making now with American foods that have been mass treated with chemicals that are now banned in the European Union and Canada. And I know for me, I mean, this goes back 30 years ago. No, it's just back 50 years for me. I'm 64. I have not ever been able to eat a mass market cereal. I was always sick afterwards. Doesn't matter if it was Raisin Bran, Cheerios, whatever. I was always sick from it. And I'd be nauseous and gassy and even dizzy. And I truly believe that that was from BHA, BHT, preservatives, which are actually endocrine mimickers and have been linked to cancer. And of course, they're banned everywhere else, but they're here. Why? Because the chemical companies want to make money, so they spin it well to Congress, and Congress won't ban it. But I'm banning it. I'm banning it for me. So like I will only buy organic flour that comes in the US. I will only buy pasta from Europe. I will not buy any American pastas anymore because all the wheat pastas here are treated with Roundup as a drying agent. Like right before harvest, they spray it with Roundup. Like, what the hell? Stop it. Stop saturating our food supply with chemicals with most other countries have banned, but we are foolishly allowing them to do it because the company makes too much money and they have too much influence. So I mean, we got to be smart here. It's sad. It's really sad what's happened to the American food supply and the massive growth of obesity and the massive growth of cancer. And we have to connect a lot of it to just environmental exposures. And I'm just really sick of companies and billionaires who are making decisions to make money and they don't care what happens to us. Period. End of story. If it'll pad their pocket, they'll say it's safe. So anyway, sorry, I got a little off topic there. Rebecca said prolotherapy works well, but you need 6 to 8 treatments. Hips are the hardest to treat. Yeah, thank you, Rebecca. Lori said, my doctor injected meds in my SI joint, which in turn helped my bladder and pelvic pain. Cool. Lori said, what med? Oh, here, hold on. Harriet says, hello, Harriet. Suffering through a horrible flare right now. Did my home rescue instill this afternoon. This too shall pass. Seeing a recommended urogynecologist on Wednesday. Honey, I'm so sorry that you're flaring today. Do you know what kind of flare you're having? Is it a bladder wall flare or a pelvic floor flare? Mary says, is estrogen cream better than Vagifem for dry skin? It's the same thing. They're both estrogen products. The advantage of estrogen cream is you can put it in different places, where Vagifem, you can only put the pill in your vagina. So a lot of people prefer the estrogen cream. Joni, I may have missed some of the things that you've written, so please ask again. Lori said, after 6 months of pain, it did come back, so I just did a radio frequency ablation, which if it works, can help my pain up to 9 months. Cool. Lena says, I fell on concrete 3.5 feet down. Now I have right hip pain and your tailbone hurt. So Lena, you need to go to a physical therapist for sure, hun. They need to do a proper assessment of your pelvic floor. I mean, when your doctor clears you, because if you have any broken bones, you got to wait for the bones to heal and stuff. But it's very, very important after injuries like that you understand that your pelvic floor is also injured. Nerves might be injured, and making sure that the proper muscles are rehabilitated is important. And this is not just about Kegels. We're not talking about Kegels at all. Kegels actually can make pain much worse. This is about finding the site of the injury, addressing the trigger point at the site of the injury, getting that muscle to relax and release and restore proper blood flow. Susan said, hey, Jill, I just had Dr. Evans put in the new Axonics InterStim last week. I was misled thinking it would help my flare-ups. He said it doesn't help with pain. Oh, my God. Girl. Ah. How many times have I said that? Neuromodulation is not approved for pain, honey. I mean, the advantage here is you've got literally one of the best doctors in the world, but I'm sorry that at some point in time, it was suggested to you that this would help pain. And maybe in a small percentage of patients it might, but in most patients it won't. But I'm glad he took out the old one. That's good. And you guys, when I'm rubbing here, I'm actually rubbing my incisions from my mastectomy, and they just, they just start to hurt after a while. Larry Ann said, I'm in full menopause at 46. I'm on an estrogen blocker called anastrozole and a monthly Lupron shot to prevent breast cancer from coming back. There you go, girl. I had my breast cancer diagnosis last May, wondering if I could use an estrogen cream. The So what my oncologist said is that I asked her about that, and she said that there is no direct correlation between topical estrogen cream and the growth of cancer throughout the body because it is not a systemic therapy. That said, anybody who's had a diagnosis of cancer and is terrified of the cancer growing is like, oh, hell no. I also have an estrogen dependent cancer. I had a double mastectomy, so technically it's gone and my lymph nodes were clear. But even I cut back and I went to once a week using a very, very small amount of my estrogen. But my oncologist was not concerned at all. You can look at the research. The vast majority of research in the last couple of weeks shows no connection between topical estrogen and breast cancer, but the fear is real. I understand that fear. Let me see if I can get that latest study because we did have one more study that came out. Let me see if I can find that for you. Hold on. All right, okay, so October 24, effect of vaginal laser and topical therapies on vulvovaginal atrophy symptoms in breast cancer patients. Okay, and this was in the Journal of Clinical Medicine. The researchers are in Eastern Europe. Oh, it's a fantastic research team. Intravaginal laser therapy is an effective treatment for vulvovaginal atrophy and breast cancer survivors, particularly in improving vaginal health and reducing pain with intimacy. Despite the strengths of the study, variability among studies, the lack of clinical trials, especially on long-term. Okay, so they don't talk about the topicals here without me. Oh, it's free. Hold on. Let me see if I can pull the whole article here. What did they find here in the whole article? The use of topical. Okay, so here, hold on. Our aim was to provide evidence-based estimate on the effectiveness of treatment for vulvovaginal atrophy among breast cancer patients. The use of topical treatments and intravaginal laser therapy is recommended for the management of moderate to severe atrophy in women with breast cancer. And let me grab that study here real quick. Okay, I'm going to give you a I'm going to give you 2 links here. Well, here. Okay, so honey, I'm going to reply to your message with a link to this, okay? So you can read through that article. And that has links to lots more articles. But ultimately, in the end, you have to talk with your oncologist about it and see what they say. I know that if I don't use a little topical estrogen at my urethra becomes very sensitive. And just last week, I felt a little dryness on my labia, and so I used my topical estrogen on my labia. But I'm not going to town and using a lot of it because cancer's scary. Tabitha said, where do you order European products from? Well, like what European product? are you interested in? I mean, I brought the European studies to America, and I've looked for suppliers with similar products in America or abroad. Right now, our lactoferrin comes from Australia, the lactoferrin that we carry, because I don't want to carry a domestic lactoferrin because of bird flu. Gina said, if you have IC and your flare up, will an Epsom salt bath help or worsen the symptoms? I think baking soda is better than Epsom salt. I think you could do, because baking soda alkalinizes the water. I did warm baking soda tubs for years when I was struggling with vulvodynia in high school and college. So I go for the baking soda instead of the Epsom salts. Mary said, would a CBC blood test show IgG levels? No, honey, it's separate. CBC looks at your blood count. I mean, there are different elements to the test. Okay, let's come back to YouTube here. Donna said, and Donna, honey, I'm sorry it took so long to answer. Did the injections work, Jill? If so, for how long? No. I'm going to say that my trigger point injections did not work. They were never able to numb where they needed to numb it. They missed it by an inch each time. So if you're talking about the injections that I had, they were not effective. And the doctor admitted, I mean, like literally, we could tell as he was doing it. It's like, nope, not there yet, not there yet. The problem is that the nerves have all these little curlicues off of them. And so the pudendal nerve, for example, has, you know, the nerves kind of come down, they come off the spine together, right? And then they merge together and they then go down both legs. But there's a little curlicue branch that goes backwards and into your butt cheek. And that's the nerve that I have compressed. And so it's a harder nerve to identify, and it's a harder trigger point to treat if it's around that area. But some people have done really, really well with trigger point injections, just not me. Because my, you know, my situation is weird. It's not a typical situation. Oh, my neck is tight. Hey, for anybody out there watching, if you want to exchange Christmas cards, I would love to send you a Christmas card. I just need you to email me your address, icnetwork@mac.com. If you email me your address, I will send you out a Christmas card because I happen to love doing Christmas cards. And I'd love to get a card back, but it's okay if you can't. That's okay. No stress. icnetwork@mac.com. Joni said, Mary, very severe burning on the pelvic floor and urethra sensitivity and feeling like I had to pee constantly. So that's why you had the, that's why you had the neuromodulation, huh? No, is that you, Susan? No, that's Joni. Hold on. So I'm here as long as you have questions, but we're definitely slowing down. We've been doing our meeting for about 2.5 hours now. I would be happy to start up a Zoom meeting so that you can talk to me if anybody would like to be phenotyped. If you would like some insight on phenotyping, I can phenotype you very quickly. So if anybody out there wants to come into a Zoom, I can set that up right now. You have to let me know. If you don't want to do it, that's fine. I'm going to go bake some cookies. I was supposed to bake all day yesterday and normally make Norwegian Christmas bread and send it out to all my family, but I was just out doing other things. And then I was going to do it today. And it's like, nope, couldn't do it today either. Maybe I'll make some cookies tonight, but I got to make Christmas bread tomorrow for sure. It's getting a little close to getting it out in the mail. Yikes. Jeannie, you would like to go into Zoom? Okay. let me turn it on. It is now on. Ooh, yikes, that is a close-up picture of my wrinkly face. Here, let me get the invite. Okay, so for anybody in Facebook, here is your link to Zoom, and let me get it over onto the other computer too. So hold on a sec. And you guys, I don't know how much lactoferrin we have left, but I've got 50 more bottles coming in this week, and then they have to send more from Australia. But I will have it. I promise you, I will have it. Okay, hold on. For you guys on YouTube, I actually have to mail it to my other computer because you're on different computers, believe it or not. Okay, it is now mailed. So now let me go over to this computer. Okay, let me grab it here. There is my Zoom link. All right, so YouTube, you guys have your Zoom link now too. So if anybody wants to come in and just have a chat with me in a small group of people where you get to turn on your camera and you get to talk and I get to ask you questions, happy to do it. Absolutely happy to do it. All right, I've got one person. Okay, so hold on one sec. Jeannie, make sure you have your mic turned off. Turn off your mic just for the moment. Okay, so again, we're going to. Sherry says, can you wait until the end of the meeting to go into Zoom? Because this actually ends it for everybody else. Well, we're almost at the end of this meeting because y'all have stopped asking me questions. But if you have more questions, I'm happy to stay, or we can do all three platforms. Amy says, can you send me the info to purchase the lactoferrin? Honey, it's in the IC Network shop. Just go to our store and you can find it. Right on the front. Okay. On the front page, there's a picture. Okay, Joni's coming in. So, I'm happy to keep all three open. But what that means is that it's really up to the people in the Zoom. If they want other people to hear them, then we can leave the other ones open. If they want the privacy, then we'll shut down the others and we're just going to be in Zoom. And Sherry, you can come into Zoom also. So let me ask. Okay, so hold on a sec. Where did my control go? My Zoom controls are being weird. Give me a second. Jeannie, can you hear me? Okay, cool. Jeannie, so I'm going to ask you this question. Do you want to have a private conversation with me, or would it be okay for other people to hear your voice and to hear your question?
I guess that would be okay.
You think that'd be okay? Okay, well, let's see how it goes. Now, you guys, for those of you on Facebook, you have the invite. If you want to come into Zoom, I'm more than happy to have you come into. Mary said she doesn't think the link is working. Yeah, it's working because Jeannie came in. I'll give it to you again. Okay. All right, Jeannie, how can I help you? What's going on, girl?
I'm the one, this isn't being recorded, right?
Well, it is being recorded because it's going across the other platforms.
Oh, okay. I guess that's okay. Um, I'm the one that was getting up 25 times a night.
Okay.
What happened was I got IC diagnosed with it about 7 years ago.
Okay.
Then nobody knew what to do. One of the doctors they sent me to did find Hunner's lesions.
Okay.
I got those cauterized, and then 2 weeks later we moved out of that state into another state, which has much better pelvic care.
Okay.
So I was always telling them I don't think it's bladder pain. It's coming from one side of my vagina.
Okay.
So they could not agree about, because I had a sling about 15 years ago. They could not agree on that. Finally moved here. The doctor said, I think your sling partially has to come out, which that did. And after about 3 months of healing, I was out of pain.
Okay.
I was in excruciating pain before that.
Why did you? So you had a bladder prolapse or a vaginal prolapse that led to the
No, I had a bladder sling for incontinence.
For incontinence. Okay, and so what that tells us then is that your incontinence was caused by very weak muscles. Is that what they told you?
Yeah, after the birth of my son,
Okay.
it never was the same.
Yeah, I will never forget this quote from one of my high school teachers. He said, "The greatest gift that a woman can give a man is to risk her life to bear his child." Because having a child absolutely runs the risk of severe long-term issues. So in your case, you suffered a muscle injury, your muscles got very weak, and you developed incontinence. So then to correct that incontinence, you had a bladder sling with mesh.
Yeah.
Okay. Okay. At some point in time, you developed Hunner's lesions. They treated the Hunner's lesions with cauterization, but now your symptoms are severe again, correct?
No, what happened was I was under a lot of stress and I couldn't go an hour without going to the bathroom, go to my doctor thinking it's a simple UTI. It's not. Went to the urologist. They did a they looked inside my bladder.
Cystoscopy, yeah.
Yeah, he said he's never seen such an irritated and red bladder.
Okay.
They checked for cancer. It wasn't that.
Okay.
But I was in a little town and they couldn't agree what to do with me. They sent me to Long Island, New York.
So you saw Rob Moldwin in Long Island?
Yes, I did.
And what did what did he say?
He discovered the Hunner's lesions, but he didn't want to do anything about them. But then the doctor in New York did, so I decided to have her cauterize them. And then that was 2 years ago. Then right after that, we moved to another state. And then I got in a really good pelvic floor neuroscience facility. And they have been taking care of me. That's the one that took out the sling.
Okay.
I mean, before I had the sling out, I would pee out blood clots. Yeah. Excruciating pain.
Yeah.
So it took me about 3 months to heal from the surgery because he had to pick it out. I mean, it was bad.
Yeah. Yeah.
So after that, I got out of pain, but I've never really had the classic bladder pain. I couldn't tell, but it felt like it was in my vagina, but I couldn't tell early on. So now it's just the frequency. I don't do caffeine. acidic and all that. So I was up to 25 times a night. Finally, after they got the sling out first, then they treated me with Botox. That helped. It got me down to about 10, 8. And then after a year, it never let up for me. So that was good, but I just couldn't sustain getting up 8 times. I'm exhausted.
Yeah.
So then they did Botox a little bit more, nothing, a little bit more at the end of the month. And then now I have to self-cath.
Okay.
I can go some, but there's more than half left in the bladder. And I have to cath at least 13 or 14 times. Insurance only pays for 6 times a day, and it's not good that I cath that much anyway. They said it's you're hurting yourself. And so then that's when they came up with the suprapubic catheter idea.
Okay, so I mean, my brain goes in a couple of different directions here. So let me ask you this: when is the pain the worst? Before you pee or after you're done peeing?
I'm not in pain. I mean, I am sometimes, with the catheter being sore, but I never really felt the bladder pain. It was the sling, I guess, all that time.
Okay, so that's shocking because Hunner's lesions would give you really severe pain on bladder fill, and then you would feel better once you pee.
I think there was some of that way back, yes.
Okay.
And I'd stop and start a lot. I used to have to just lay in warm water to even make the pee come out. You know what I mean?
Yeah. When was the last time they looked in your bladder?
They're going to look into it tomorrow.
Good.
So I'm going to have them check that. And that's when I'm supposed to have the procedure tomorrow.
And the procedure tomorrow again is what?
Suprapubic.
Okay.
Yeah.
So,
but before they do that, I'm going to say, look in my bladder, tell me if it's irritated and red still, because it has been.
Okay. One of the things that I point out to patients is, bladder pain is centered. It's right above the pubic bone. So if you have pain to the left or to the right of center, that's not generally the bladder. I mean, you could have maybe a Hunner's lesion on the left side of your bladder, but remember, your bladder is fairly small. And even if it's full, it's not. I mean, let's see. I have a sample bladder here.
Yeah, they found 3 of them. And then they were cauterized, and that did help us. I mean, I had pain from the sling plus the bladder a little bit.
And did you have a hysterectomy too? Did they take your uterus?
Nope.
So we do have one case study of a woman who had severe Hunner's lesions, and she had incontinence, and she had a prolapse, and so her prolapse was so severe they had to go in and surgically replace it. And when they did that, they made a remarkable discovery that her uterus was facing backwards. The front of her uterus was facing back, and the back of her uterus was facing front because one of the ligaments was broken. And so her uterus was free swinging, and she had what essentially became a strangulation injury. So,
But they would know that because I've had surgeries and I've been under procedures and I've been under anesthesia 5 times.
I know. I know. It is weird. It's just important to know that supports a neuroinflammatory source of Hunner's lesions, because when they untwisted everything and they got everything back into position, her Hunner's lesions healed completely, and she's considered a total cure. And so kind of like there's a part of me that's wondering, if you have kind of a prolonged kind of neuroinflammatory process left over from the mesh that could be contributing. But see, but you're not having the classic symptom of a Hunner's lesion, which is pain on bladder fill. So
I did weigh that.
But you're not having it now.
No, because they cauterized it.
I know, but if the Hunner's lesion had recurred, you would have pain. You would have pain on bladder fill again. So
right, maybe they haven't reoccurred.
They might
not. That's what I'll ask them tomorrow.
So again, it might have been the result of a neuroinflammatory process that they repaired when they did your surgeries. So, but let's go down this line of thought here for a moment. So again, here's your pelvis, here's your bladder. It basically sits right above the pubic bone. Okay. So you were saying that you have pain on the left side, kind of through your vaginal.
Well, it was on the left side of my vagina. Okay. And then it was when I would fill an empty, yes, there was pain.
So
I was having pain from the sling plus the lesions, I guess.
Have you worked with a physical therapist at all in the last year, and have they assessed your pelvic floor?
I'm working with one now.
And what did she find on her examination? Were you tight on the left side, tight on the right side?
I'm very tight, and my hips are bothering me, and I went all towards, the hip doctor, the x-rays, the surgeon. My hips were fine. It's all connected to the tight pelvic.
Okay, so how much physical therapy have you done so far?
About 2.5 months.
Okay, so you're going to be.
I did it years ago too.
So you're going to be in physical therapy for probably 6 months.
Yeah.
Okay, I mean, and the question you've got to ask that physical therapist is, are my muscles responding, or are they always locking back down tight? If they are always locking down tight, we got to figure that out. We got to make sure you're not doing things that are exacerbating that, like running, like being on a Stairmaster. Your goal right now is to keep your hips as level as possible. And you want the physical therapist to watch you walk. Are there any biodynamic issues happening when you are moving your body? And specifically your hips, your knees, and your feet. There has to be a reason why your muscles are very, very tight. So you are in a state of what we call ischemia or ischemia. Your muscles are so tight, they're squeezing nerves and they're squeezing blood supply. And that causes trigger points, and that causes pain. And it's not typical bladder pain. It can be pain to the left or pain to the right. So, getting the suprapubic cath is going to give you a temporary respite, but it's not a long-term solution here. And it's going to lead potentially a little bit more trauma and a little bit more scar tissue. So I love your idea of just having your doctor look at your bladder first.
Yeah.
And listen, if all's good in there,
I wouldn't do it if all is good.
Yeah, if all is good in there, then we know where we have to work. We got to work on muscles, and we got to work on nerves.
Okay.
So one of our members, Sue, she was very interesting, and I don't know if she's in here right now because I'm not looking at my Facebook. I'm not looking at my Facebook feed right now. Sorry, Facebook. And Donna, I'll be back. Okay, hold that thought. Sue's case was very interesting because whenever she did physical therapy, so she didn't respond to bladder treatments per se, and whenever she went to physical therapy, it always hurt in one spot. And see, physical therapy shouldn't hurt, especially over time. Things should get better. But hers, every single time it hurt in one spot. And it turned out she had a mass of scar tissue exactly where it hurt. And the scar tissue was kind of woven through the muscles and around the nerves. Very complex presentation, so much so that the doctor, who is a very, very well-known doctor in IC circles, was like, that's too complex for me. I think I want you to go see a real expert in this type of surgery. So I have to kind of wonder again, if you have a negative bladder, if we're dealing with a legacy of scar tissue from your
Okay.
from your surgery, maybe. I mean,
Yeah, I'm just gonna see what he says,
I hope
how
he'll do,
my bladder looks.
and I hope he'll do a vaginal exam. I mean, before he does that, just to try to palpate the area. I mean, if he's willing to do that, just say, listen, again, left side vagina, gynecologist isn't finding any, I mean, isn't finding something. I want you.
Well, when they took out the left side of the sling, that pain got better.
Okay. Yeah, it really sounds like you're dealing with a little bit of scar tissue here. Also, listen,
Okay.
for the inflammation, again, the lactoferrin study found that red inflamed bladders after 4 months became pink and healthy.
Wow.
You got nothing to
I'm
lose.
gonna get some, definitely.
Yeah, it's in the IC Network shop right now, and no side effects. I
Okay.
mean, it's just a protein from milk. So it's not like a drug made in labs. This is just a very natural approach to immune development. And that study was truly remarkable for doing the before and after and showing these red bladders becoming pink and healthy. So,
Yeah, I just don't know why I'm still urinating so much. My bladder, since the two Botox, it's holding much more like I measured. Like one time I went 7 ounces and then I catheterized out 7 ounces. So that's huge for me. 14 ounces compared to 1.75 was all I was holding a couple of years ago.
mm-hmm, mm-hmm,
So it shows me my bladder can hold that.
mm-hmm, mm-hmm. Well, what you're dealing with is something called waking bladder capacity as compared to a sleep bladder, anesthetic bladder capacity. When you're under anesthesia, they often can get much more in your bladder than when you're awake, because when you're awake, you are sensing, you are actively sensing the alpha afferent nerve in the bladder wall, which is telling you when you need to pee. That's called avoiding cystogram, where they slowly fill your bladder and say, hey, tell us when you need to first feel the need to urinate.
Yeah.
And that gives
Yeah.
us a better idea of what your bladder sensitivity and capacity is like when you're awake as compared to when you're asleep. So, well, good luck tomorrow.
Yes,
And
I've done that twice, yeah.
yeah, I really, really hope would you pop me an email and let me know what they find?
Okay, so it's icnetwork@mac.org.
Mac.com. Yeah.
And how do you get to the regular IC network to buy that stuff?
icnetwork.org and just go into our shop.
Okay, that one's .org.
Yeah.
Okay.
And let me, hold on a sec. Let me just take a quick look here. Let me just see I've got 50 more bottles coming in this week. Let me just see where we are right now. I've got 19 bottles left in inventory, so you can get it now. Okay.
Okay.
Okay, honey.
So what else should I ask them tomorrow? How it looks?
How it looks, and specifically on the left side, just out of curiosity, since you're discussing left side pain, is it?
No, that's gone since the sling has been out.
Okay.
There's no more left side pain.
Okay. Yeah, really, it's just going to be, what do they see, hon?
Yeah, because I'm still waking up every 2 hours. At like 2 hours is the most I sleep.
Yeah, well, but 2 hours is good compared to where you were. I guess the other question you're going to ask him is, hey, if you find a lesion, what are you going to do about it?
Okay.
If you find a lesion, are you going to cauterize it or are you going to inject it with a steroid? Give me your treatment plan before we go in there. I don't want you to leave a lesion untreated. If you see it, but again, you don't have pain on bladder fill, so the odds of you having a lesion are really low. But
Right,
that's an
right.
important, that's just an important question to ask is, what do you plan to do when you get in there if you see something funky?
Okay.
Okay.
If it's all pink, I won't go through with this suprapubic catheter.
Yeah,
There's
I
something else
wouldn't.
going on.
I wouldn't, because I wouldn't want to damage your bladder. I mean, that's creating an incision in there. I mean, it's a surgical procedure. It's a traumatic
Right.
procedure, and if your tissue looks good, then clearly you've got a healthy bladder, and we've got other things that we've got to work on, like your central nervous system and your muscles instead.
Okay, what if I have a really red and irritated bladder? Which is what it has been in the past.
Then I think that I would probably want if I were in your shoes, I would want a biopsy. I would want them to look at that tissue to try to understand what's happening in that tissue.
They did that at first when it first was diagnosed.
Mm-hmm. Okay, but I think it would be worth.
Do it again?
Sure. I mean,
Okay.
otherwise everybody's guessing, and we need more facts. I mean, remember,
Yeah.
Hunner's lesions have been connected to viral infections. Now, will a biopsy identify viral infection? I don't think so. But it'll identify a mast cell issue. It'll identify eosinophilic cystitis. It'll identify cancer.
Yeah.
I mean, if it's very, very red and inflamed, he's going to want to do a biopsy anyway, most likely, just to try to understand it.
Okay, and then just wait on the catheter again if it's too red.
I don't know. I really, truly don't know. I mean, because again, you're just not having bladder wall symptoms right now.
No.
If you don't have pain on bladder fill, then that tells me that your bladder wall is actually probably doing pretty well. If you had severe pain on bladder fill and your bladder pain got better once you peed, then yeah, that tells us your bladder wall has a problem. But you don't have that right now.
No, I don't. Right.
And so it's my guess, my $100 bet would be that your bladder wall might be inflamed because the nerves in your area are inflamed. There may be some neuroinflammation going on from the mesh, just leftover from the mesh and that massive inflammation that the mesh would have caused. But is there something fundamentally wrong with the structure of your bladder wall? You're not having the symptoms that suggest it, but we don't know. We're guessing. You deserve more than a guess. So I'm really glad you're letting your doctor do that hydrodistension tomorrow. The other thing that I think you need to ask is, are you going to treat the pain?
No, he's just doing a cystoscopy.
Okay.
No hydrodistension.
Okay. Still worth the question. If I'm in pain afterwards for, let's say your bladder's super, 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 super red, then it's nice to have an assurance that they will give you a couple days worth of pain meds. Because your case is unique because of your previous surgical history. Your nerves are more sensitive because your previous surgical history. So you might benefit from a little bit of pain care if necessary. I would just want the assurance that they're going to be there for me if I'm in pain.
I guess it's just going to be hard in that moment to make up my mind whether to go ahead with the suprapubic catheter. Because that's what I'm scheduled for, but I don't know what to do.
You won't know, and honey, you don't know what to do, and I don't know what to do, and your doctor doesn't know what to do right now. You have to let them look in your bladder first.
Yeah, right, exactly, and I don't mind that. I've had it done so many times, but I just don't want to do it if, I'm desperate for sleep, but I don't want to put something foreign in there if it's going to cause more trouble.
Well, yeah, and and potentially introduce bacteria and all sorts of stuff. So I mean, I completely agree with you. I think your decision making is sound here, But ultimately, in the end, you're agonizing over something for which you just don't have enough information. You're just going to have to wait until tomorrow, lots of deep breathing, and let's see what they find. And you can say, hey, you know, what makes my case so weird, doc, is that I don't have the bladder symptoms that most IC patients have. I'm just getting up every night, every 2 hours. But are you diet sensitive? Do foods make you worse?
Not really. I don't know.
Can I hear a round of hell yeah? What does that prove? What does that prove? If you're not diet sensitive, then that means pretty much you have a healthy bladder wall, other than maybe a little estrogen atrophy. And again, that pushes us away from the Hunner's lesion idea and right towards instead a neuromuscular origin for your pain. I mean, if you're not food sensitive, then you've got a pretty healthy bladder wall. I mean, unless your bladder's numb, but I don't think your bladder's numb. So anyway, keep in touch.
Yeah, because the lesions were there and they did cauterize.
Well, I know, but that was a long time ago.
Yeah, 2 years.
Well, no, 2 years is not a long time ago. 2 years is a short time ago. Well, it'll be interesting to see what they find. You'd be the first Hunner's lesion patient I've worked with who was not diet sensitive. Almost every IC patient is very, very diet sensitive. And they are in severe pain if they drink coffee or tea or soda. They are the patient.
Yeah, but I'm not now. I might have been then, but
yeah. Well, let's just don't agonize tonight. You've made a good decision. It's good to have the cystoscopy. We're taking out a guessing into fact. Let's see what they find. And pop me an email and let me know.
How do I get in touch with you if I want a phone call? Just go through the email?
The phone number is right on the website, right at the top page.
Okay.
Okay, just know that Mondays are my day off, so I don't answer the phone. I try not to answer the phone on Mondays, although sometimes I do after 2. It's always better to catch me on Tuesdays or Wednesdays. Okay?
Okay. Yes, thank you so much.
Okay, talk to you later.
All right, bye-bye.
Bye-bye. Okay, we have somebody else in the room. I'm not going to say your name unless you say it's okay for me to say your name. And do you want other people to hear you, or would you prefer that it be private?
Well, this is John.
Hi. Yes, I know. I'm trying to give you privacy because right now we are still live on YouTube and we're still live on Facebook.
Privacy would be better. Yes.
Okay. So hold that thought. Let me go over here. You just give me a couple minutes at the most. All right. Sorry, you guys. You would never know I washed my hair today. It's all ratty, and I don't know why. Lori says, Peora, have you gotten feedback on disturbed sleep or odd dreams with Peora? I've taken it for my bladder. My husband has taken it for cervical disc issue. Good for pain, but you have both experienced strange dreams. I have never had strange dreams. I'm not aware of any research which has found that. But let me do a quick search for you. I can do that, and let us see. Hydroxyzine is the one that is known for causing weird dreams. We call them hydroxyzine dreams. No, there's nothing in the National Library of Medicine on that, honey, Lori. But, what do they say? See, the cool thing about the Peora is that the results are what we call durable. They last for longer periods of time. So you could stop it for several weeks and see if the dreams go away. And if they do, then okay, for you, there's something about them that gives you funky dreams. I mean, pretty much the side effects are nil in the great majority of PEA studies, and there are no known drug interactions. But everybody's different. It's just weird that it would be you and your husband. It makes me wonder if there's something else going on also that you're both exposed to besides the PEA. Something as simple as scented candles or room spray in your home, something like that. Even a Christmas tree. Some people are allergic to Christmas trees. Like me, I can't do Christmas trees anymore. So, all right. So for you guys on Facebook, thank you for hanging out. I plan on being here next Sunday, and we're going to do our pre-Christmas meeting. In the meantime, if you find these meetings helpful, please come on over to our website, icnetwork.org. Sign up for our free newsletter. I sent out a massive newsletter, first one in 4 months, last weekend. So I don't bombard you with spam at all. I would just really try to do genuinely helpful and encouraging things. All right, my friends. So I'm going to say goodbye to YouTube right now. I hate to because it's a big room, but if you want to come in, you have the link to Zoom. If you want to come in and hang out and talk personally, come on in. All right.